This is the hearing that the Republicans refused to have on the repeal of the Affordable Care Act. I'm going to make a statement which will refer to that, but I first want to start our hearing by yielding to our leader. Before I yield to her, however, I want to say, in my view, there is not a single person in America, not one, with all due respect to the President Obama, who I think did such an extraordinary job as our President, not a single person more responsible for the passage of the Affordable Care Act and the extending of insurance access to all Americans than the then Speaker of the House of Representatives, Nancy Pelosi. So I'm very proud and pleased to yield to her at this time to start this hearing. Leader Pelosi.
Thank you very much, Mr. Hoyer. Thank you very much, Whip Hoyer, for bringing us together and for your extraordinary leadership on this. It certainly, I accept your compliment on behalf of all of our members who had the courage, the intellect, the wisdom and judgment to support the legislation as we go forward, and always recognizing there's never been a perfect bill in Congress and that there would be opportunities to improve as we saw implementation. So thank you for this very important hearing. So important because the Republicans have refused to have hearings, but we would like to work with them on any improvements to the legislation that they might suggest. So it's an honor to be here with you, Whip Hoyer, with our ranking members on the Committee of Jurisdiction, Ranking Member Pallone, Ranking Member Richie Neal, Ranking Member Bobby Scott, and pleased to join you in welcoming our public members who are the first panel, Doug Elmendorf, Andy Slavitt, and Mike, our former colleague, Mike Riedler from Washington State. So here we are. Whip Hoyer, again, thank you for organizing this hearing to examine the impacts of the Republicans' Pay More for Less bill for a hearing the Republicans refused to hold. Republicans have done everything they can to stop the public from discovering the reality of their attack on Americans' health care. But this week, the CBO exposed the Republicans' Pay More for Less bill as a merciless attack on the working families that it is. Merciless attack when the Speaker calls this legislation an act of mercy. An act of mercy. An act of mercy for whom? Is it an act of mercy for the 24 million people who will lose their health care so that Republicans can hand billionaires a massive new tax giveaway? The bill steals $600 billion from working families and gives it to the rich. It's Robin Hood in reverse, one of the largest transfers of wealth from working families to the rich in history. Under Republican plans, deductibles and out-of-pocket costs will go up for families across America. As we all know, a 64-year-old with an income of $26,500 in the individual market will pay $12,900 more for their premiums every year. They will pay more in premiums than over half of what they make in income. Speaker claims, again, as an act of mercy, to make Americans pay more for less health care and push 24 million off. Is an act of mercy to shorten the life of the Medicare Trust Fund by 3 years and steal $880 billion from Medicaid. Is an act of mercy to abandon Americans fighting addiction, to shut down rural hospitals and destroy jobs across our country. Now we hear Republicans are planning changes in the Rules Committee which could significantly worsen the already disastrous impact of their bill, including a proposal to destroy millions of Americans' Medicaid coverage as soon as the end of this year. As I wrote to Speaker yesterday, the public deserves to see an updated CBO score on the consequences of the final GOP legislation before any vote by the House. The American people deserve the facts, and really so do our colleagues who have to vote on this before the House votes to destroy affordable health care in our country. Again, we are honored to be joined by some of the leading health experts in our country with years of experience and understanding of our health care system. They're here to offer insight and wisdom on the devastating impacts of the Republican plan, and I assure them that we have the humility to accept positive suggestions about how to improve the Affordable Care Act, but we do not support a repeal which would have the devastating impact that the Republicans are proposing. Republicans should pay attention. What we put forth was really a Republican idea, developed by the Heritage Foundation, supported by Mitt Romney and Romney Care in Massachusetts, a marketplace solution, a free market idea. And in any event, if you don't believe in governance and the role of government in the public-private partnership of providing health care to all Americans, then you go down the path they're going down. But we believe that health care is a right, not for all, not a privilege for the few. We believe that the Affordable Care Act has been successful in meeting its goals of lowering cost, of expanding access, and improving benefits. Can we do better? Yes, and we'd like to do that in a bipartisan way. We invite the President and our colleagues to join us in that regard. With that, Mr. Chairman, Mr. Whip, I thank you again for the opportunity to say a few words here. Thank you for this important hearing, and yield back.
Thank you very much, Madam Leader. And again, I want to reiterate how critically important Speaker Pelosi's leadership was in passing the Affordable Care Act. In my opinion, without her leadership, it would not have passed. And I was proud to work with her, as were all the members here at the dais who were in Congress at that point in time. There's some who are not. I'm glad to be joined by Ranking Members Pallone of the Energy and Commerce Committee, Ranking Member Neal of the Ways and Means Committee, and Representative Scott, the Ranking Member on the Education and Workforce Committee. All of them were very critically involved in the passage of the Affordable Care Act, as well as other House Democrats who are here with us, and I'll recognize them. I do want to recognize, however, former ranking member of the Ways and Means Committee, Sandy Levin of Michigan, who has been one of the leaders on this effort. And I'll recognize the other members as I recognize them for questions. Democrats are holding this hearing on the impacts of the Republican bill to repeal the Affordable Care Act because Republicans refused to hold a single hearing on their bill. Incomprehensible that they would adversely affect 24 million people at least, but in fact they will affect adversely every person in America who will see higher costs and less access. In matter of fact, Speaker Ryan originally said, well, this will give everybody access to insurance. He then modified that a day later and said, this will give everybody access to the care they can afford. Those were added 2 days later because he recognized that there are millions of people who cannot afford and will not have access. Not one of the three committees marking up the bill, and you'll hear from our ranking members, heard a single minute of expert testimony or from any of the tens of millions of Americans who will be negatively affected by its provisions. We believe that legislation of such substantial impact, catastrophic impact in many instances, ought to be subject to scrutiny and transparency and the opportunity for the American people to be involved and to have their voices heard. Democrats are determined to ensure that the American people know what this bill would do and what impact it would have on our people and our economy. That's why we've also launched resistrepeal.org. We are streaming this hearing live on that resistrepeal.org social media, as well as on my Facebook page. So citizens can go to either one of those pages and hear this hearing for themselves, because they need to have the information of what this proposal will do to them and their families, their neighbors. As you can see from the map on the screen, do we have that map right behind me? Many Americans have already logged on and weigh in from across the country, logged on to resistrepeal.org. Today we're going to take a closer look at what the Republican repeal bill would do and how it will impact patients, doctors, families, small businesses, the Medicaid program, Medicare, the states, and our economy as a whole. It is somewhat ironic that the Republicans are having trouble, as they have now for 5 or 6 years, creating some unity in their party. The irony is there are some of their members who say this program that they have proposed hurts too many people. The other faction says it doesn't hurt enough people. We will have two panels, the first on the bill's economic coverage implications and the second on perspectives from patients and providers. But first, I'm pleased to yield to my friend from New Jersey, the ranking member of the Energy and Commerce Committee, Mr. Pallone.
Thank you. I want to thank our Democratic whip, Mr. Hoyer, for scheduling this hearing today. Would you believe this is the first hearing on Capitol Hill on the House Republican repeal bill? Republicans refuse to hold hearings on this bill because they don't want the American people to really know what's in it and how it will affect them. But fortunately, the nonpartisan Congressional Budget Office released its findings earlier this week, confirming what we had heard from other outside experts, and the CBO's findings are devastating. 14 million people would lose their health coverage next year, and that number would increase to 24 million in 10 years. Today, the number of uninsured is at a record low thanks to the Affordable Care Act, and the Republican repeal bill would erase all of those gains. We really should call this bill Ryan Hood, Robin Hood in reverse. CBO found that the Republican repeal bill would cost $880 billion over the next 10 years for Medicaid, all in order to pay for tax cuts for the rich. That's a 25% cut in Medicaid. Today, 1 in 5 Americans receives health insurance from the Medicaid program. It finances more than half of all births, and 70% of all nursing home residents rely on Medicaid. If these drastic cuts go into effect, how are states going to continue these critical services? They simply won't. The Republican repeal bill would also institute an age tax, which would allow insurance companies to charge older Americans 5 times more than their children. How are older Americans supposed to afford that when they're trying to save for retirement? And CBO's conclusion that older and sicker Americans simply will go without health coverage. Well, that's unacceptable to me, and I know it's unacceptable to all of my Democratic colleagues. The Republican repeal bill also doesn't protect people with pre-existing conditions like the ACA does. Protections only apply to those who maintain continuous coverage. If someone has a lapse in coverage, insurance companies can charge a person a 30% sick tax on top of their premium. People who have pre-existing conditions are more likely to go without coverage for a period of time when they're sick, and this penalty would hit them hard. And finally, all Americans will pay more for less. CBO projects that out-of-pocket costs will skyrocket because insurance plans will have few, if any, limitations on the level of deductibles and copays. So simply put, Americans will not be able to afford their health care. Mr. Whip, as I said, the only people who benefit from this bill are the wealthiest few. It should never come to the House floor for a vote, and I look forward to hearing from our witnesses today. And thank you again for holding this hearing.
Thank you very much. I now want to recognize Ranking Member Neal, member of the committee when this bill passed and a leader in that effort.
Thank you very much, Mr. Hoyer. And let me welcome back Mr. Elmendorf. Delighted that he's here. And one of the great parts of the CBO is that even when I disagreed with what he had to say, I never questioned the veracity of what he had to say. And I think that these are careerists. They are people that do an extraordinary job. And based upon what the leader said today, if the manager's amendment radically alters what they've already proposed, then I think it's time for another CBO score as well before they move forward. A couple of statistics this morning that I think that are really important. In the state of Massachusetts, 100% of the children are covered. 97% of the adults in Massachusetts are covered. And when the satisfaction rate is polled, it regularly polls in the high 70s. What we're witnessing here today is an opportunity, as duly noted, to have the hearing that never took place. A reminder of how many hearings we held and how many committees that we held over the course of almost 2 years. But the reality of what Republicans have offered is that this bill does not lower costs for consumers. In fact, consumers will face higher costs and less value. In addition, it's been acknowledged that, unlike what President Trump proposed, the CBO estimates that 24 million fewer Americans will have coverage under this Republican scheme. This is really a tax cut, disguised as a health care bill. The bill would cut $880 billion from Medicaid, which helps provide the cost for more than 60% of all nursing home residents nationwide. People understand, I hope, that very quickly Medicaid has become our long-term insurance program in America. It would also harm my state of Massachusetts by cutting Medicaid funding that is used to pay for opiate addiction treatment, long-term care, and children with special needs by cutting the tax credit that helps families afford coverage in the mass connector and by letting insurance companies reduce the value of the coverage they offer. We know that there will be more uninsured, which means a greater burden on local hospitals. We'll see job loss and hospital closures, that's something our communities cannot afford. I listened to a fellow this morning as I was getting ready to come over who said, I don't need health insurance. I should not be bound by the mandate. I should not be told that I have to have health insurance. I thought to myself rhetorically this morning, if he's in a serious accident, then who ought to pay? And that's the real issue in front of us today. All of us are burdened with at least $1,000 a year in our own health care plans to take care of that attitude. And I think that one of the things that's very, very important here is that in the writing of the ACA, the Ways and Means Committee was heavily involved in that, we kept the private sector alive for the purpose of offering discipline to price. That was the reason. And I think that they, in the last few days, have demonstrated that they have no interest in any of that as they proceed with a political ploy to provide less health insurance for the American people. And I want to thank Mr. Hoyer for having held this hearing this morning.
Thank you, Ranking Member Neal. Appreciate that very much. Now I'm going to turn it over to the Ranking Member of the Education Workforce Committee, Mr. Scott from Virginia, who will make comments and then introduce our first panel. I'll go through the members that are here, but I'm going to recognize them for questions. But let me just go. Dwight Evans was here. He stepped out for a second. Diana DeGette, Congresswoman Colorado. Raja Krishnamurthy from Illinois. Ron Kind. Sheila Jackson Lee. Ron Kind is from Wisconsin. Sheila Jackson Lee from Texas. Rick Larson from Washington State. Keith Ellison from the great state of, why am I drawing a blank? Minnesota. Gene Green from Texas. I've been with a lot of Texans today, Keith. Sorry about that. Sandy Levin, I've already introduced from Michigan. Tulsi Gabbard from Hawaii. Kathy Castor from Florida. And Jan Chakowski from Illinois. And Don Byer from Virginia.
Thank you, Stenny, and thank you for convening this hearing that should have taken place a long time ago. As we discuss the Affordable Care Act, I think it's important to remind ourselves what the situation was before the Affordable Care Act passed. Costs were going through the roof. Those with pre-existing conditions could not get insurance. Women were paying more than men. And every year, millions of people were losing their insurance. We passed the Affordable Care Act, and now the costs have continued to go up, but at the lowest rate in 50 years. Those with pre-existing conditions can buy insurance at the standard rate. Women aren't paying more than men. And instead of millions of people losing their insurance every year, 20 million more people have insurance. Now, the full name of the Affordable Care Act is the Patient Protection and Affordable Care Act, and we have patient protections, like your policy can't be canceled because the insurance company decides that they paid too much. With prevention and cancer screenings, no copays and deductibles. We're closing the donut hole. Those under 26 can stay on their parents' policies. We funded community health centers. We've made investments in education so that we can produce more doctors and nurses and other professionals. And during all that time, the Medicare trust fund solvency has been improved. Still, it's not perfect. But if we're going to make a change, we ought to improve the situation, not make it worse. Incredibly, every proposal the Republicans have come up with actually makes things worse, especially their replacement plan. Now, we know that CBO has confirmed what we already knew. Fewer people would be covered. Everybody else would pay more and get less. And rhetoric can't cure that problem. You can't fix it by saying that somebody who's paying $100 a month now, mandated to pay $100 a month now, is better off because the price went up to $1,000, but now they have the freedom to be uninsured. We have to recognize the program for what it is. Now, all the while you're inflicting pain on people, wealthy, the top 2% get massive tax cuts. And all of that is if the proposal works. The CBO talks about stability. And we have the commissioner from Washington State who will discuss what happened in Washington State when you tried to cover people with pre-existing conditions without universal coverage. Now, Mike Crowder, the Washington's 8th insurance commissioner, he's a former member of Congress. We were elected together in 1993. He's been insurance commissioner since 2000. He was reelected to his 5th term last year. He's a doctor of optometry with a master's degree in public health from UCLA and practiced in group health cooperative in Olympia for 20 years. He also served 16 years in the state legislature, and he's a retired lieutenant colonel from the Army Reserves with 20 years of service. We'll hear, I guess, first from Doug Elmendorf, Dean of the John F. Kennedy School of Government at Harvard University. He served as the director of the CBO from January 2009 through March of 2015. Prior to joining CBO, he was at Brookings and director of the Hamilton Project. He previously served as an assistant professor at Harvard, principal analyst at CBO, and a senior economist at the White House's Council of Economic Advisors. We'll also have Andy Slavitt, who is a former acting administrator at the Centers for Medicare and Medicaid. In addition to Medicare and Medicaid, his portfolio included the Children's Health Insurance Program and implementation of the Affordable Care Act by way of the marketplaces and healthcare.gov. Prior to joining CMS, he spent 20 years in the private sector, and so we're very delighted to have all of our speakers, and we'll start with Dr. Elmendorf.
Before Dr. Elmendorf, I want to make an observation. I believe that Dr. Elmendorf, who was an extraordinary director of CBO, is about to testify, and the public ought to know this, very similarly to the findings of the present CBO director. Now, what's the point? Dr. Elmendorf was appointed when a Democratic Congress was in place. Mr. Hall was appointed by a Republican Congress. Americans are asking for bipartisan advice and counsel. They are getting it today. Dr. Elmendorf.
Thank you, Whip Hoyer, for the kind words. Thanks to all of you for the invitation to be here today. I'm delighted to be back on the Hill. The health care legislation supported by the Republican House leadership would take our country backward, not forward, in my view. It would do that in at least 4 important ways. First, the legislation would entirely reverse the progress of the past several years in expanding health insurance coverage in this country. The number of uninsured Americans under the age of 65 was 50 million in 2010, is 26 million today, and would be 52 million in 2027 under this legislation, according to CBO's projection. That is a doubling in the number of uninsured Americans. To be sure, CBO's projection is probably not entirely accurate, just as the projections we did for the Affordable Care Act were not entirely accurate. But there is no evidence to suggest that the government could cut subsidies through the insurance marketplaces in half, as this bill would do, and make unprecedented cuts in Medicaid without dramatically increasing the number of Americans who do not have health insurance. Second, that dramatic increase would not primarily be a result of people having greater freedom to choose to be uninsured. It would primarily be a result of people not being able to afford health insurance. Yes, the elimination of penalties for not buying insurance would cause a sharp decline in insurance coverage in the next few years. But the 50% cut in the average subsidy in insurance marketplaces by the end of the decade would greatly reduce the affordability of insurance. And the projected loss of coverage in the long run is concentrated in people who would lose eligibility for Medicaid. If you lose eligibility for Medicaid, you are not deciding to become uninsured. You are losing your access to health insurance and affordable health care. The evidence is clear. The bill is not as much about giving people more choices as about taking away their existing opportunities. Third, the removal of opportunities in this bill would not represent shared sacrifice for the national good, but rather targeted sacrifice by lower and middle income Americans. The government currently subsidizes health insurance and health care for nearly all Americans. Support provided by the Affordable Care Act, but also support for elderly Americans through Medicare, for some lower income and disabled Americans through Medicaid as it existed prior to the ACA, and for 150 million Americans who receive health insurance through their employers and can exclude that insurance from their taxable income. That tax exclusion provides most of its benefit to higher income Americans. 34% to the top 1/5 of the distribution, but only 22% to the bottom 2/5 put together, according to estimates that CBO did several years ago. The Republican bill would not scale back all of the existing tax subsidies in a way that shares the burden. Instead, it would leave the tax subsidies for higher income Americans fully in place and clobber the tax subsidies and spending subsidies for lower and middle income Americans. Fourth, the legislation would take us backward by providing a large tax cut focused on the very top of the income distribution. We know that many Americans have benefited relatively little from the growth of overall national income during the past few decades, while people at the top of the income distribution have done very well. Indeed, a central theme of last year's election campaign was the importance of government policy focusing more effectively on the needs of people who are not the economic elite. Yet, the 1% of households with the highest incomes would receive 40% of the gains from repealing the tax provisions of the Affordable Care Act, according to estimates by the Tax Policy Center. Are there other advantages of this legislation that would offset all of those ways in which the legislation would take our country backward? No. There is no need to make dramatic changes to the ACA. Although the insurance marketplaces are not attracting as many enrollees as many of us would like, they are not in a death spiral, and the competition among private insurers in the marketplaces could be strengthened through modest policy changes. In addition, the vaunted deficit reduction from this bill represents just a few percent of projected deficits under current law. Certainly every bit helps, but this bill is not a significant part of a true deficit reduction strategy. Moreover, the small reduction in average premiums in the long run from this bill would occur largely because average out-of-pocket costs would rise considerably and because older Americans who need more health care would be less able to afford insurance and therefore would not be in the risk pool. Those are hardly accomplishments to write home about. So why is this legislation on the table now? Why is it the most important priority for House Republicans? I'm baffled, frankly, that anyone could have watched last year's election campaign, seen the frustration and anger of many working Americans, and concluded that the most important thing they could do for our country is to make health care unaffordable for tens of millions of Americans who can afford it now, while cutting taxes for the richest Americans. In some ways, the administration seems to understand this point. The president promised not to cut Medicaid benefits and said that everybody is going to be taken care of much better than they're taken care of now, and the government's going to pay for it. The Secretary of Health and Human Services said nobody will be worse off financially. The Secretary of the Treasury said there would be no absolute tax cut for the upper class. All of those promises would be broken without a doubt by this legislation. Thank you.
Thank you very much, Doug. Mr. Slavin.
Whip Hoyer, Ranking Member Pallone, Ranking Member Neal, Ranking Member Scott, and Congressmen and women. Thank you for the invitation to participate in the public hearing on the economic and coverage implications of the American Health Care Act. I'm Andy Slavitt, also from the great state of Minnesota. From 2015 to 2017, I served as the acting administrator of the Centers for Medicare and Medicaid Services.
I'll remember that in the future.
Spent a lot of time in Maryland the last couple of years. I joined the administration after spending several decades in the private sector, leading a large healthcare services company. And I joined the government after the launch of the ACA as part of the team leading the turnaround and helping oversee the implementation of health reform. As such, I have a unique and I think a balanced perspective on the successes and challenges of the ACA. It's important to recognize what has been accomplished under the ACA and where the bar for progress has been set. Only a few short years in, and the uninsured rate has been cut nearly in half. Over 100 million Americans are protected from pre-existing conditions, and equal numbers are protected from gotcha insurance policies with caps and limits and uncovered services like mental health and maternity care. Whatever happens next, whatever we call it, we must measure it against the benchmark of what the ACA has accomplished. If 4 years out, we have covered more people than we are covering today. With higher quality and affordable coverage, it will be judged a success by the American people. If, on the other hand, people lose coverage or that coverage becomes more expensive, it will represent an enormous step backward for the American people. It is for that reason, I believe, that to a group, physicians, nurses, hospitals, retiree groups, medical students, and countless patient advocacy groups have expressed deep concern about the proposed American Health Care Act. Why? An estimated 14 million Americans are projected to lose coverage next year, and the cost of insurance would increase by 15 to 20%, according to the Congressional Budget Office. And within a few years, all of the gains in coverage, health outcomes, and financial security would be more than reversed. I want to look at the particular impact of the bill on kids and on seniors. Kids would be hit very hard. Thanks to Congress's work on CHIP and on the ACA, the uninsured rate among children has dropped to a historic low of around 5%. This AHCA makes insurance unaffordable for many families and makes a radical cut to Medicaid. $880 billion, or as much as 25% of the Medicaid program, would be cut and then placed under a cap. Kids are one of the major beneficiaries of Medicaid. In fact, half the babies born in the country are paid for by Medicaid. The cuts in this will very likely have the effect of cutting off and rationing care for many children. Seniors will be hit tremendously hard as well, as the premium increases and tax credit reductions would add nearly $13,000 or more than the cost or more to the cost of a policy for people just under 65. Given that the average senior who buys a policy has an average income of $25,000, this is a scary prospect for many. Once they hit 65, seniors would face a new crisis, as under the AHCA, the Medicare Trust Fund's life would decline by 3 years to 2025. And of course, the same Medicaid cuts that would hurt kids would also hit long-term care. And Americans count on Medicaid to pay for half of all their long-term care needs. In fact, under the AHCA, the cost of insurance gets radically more expensive for many, as help with deductibles and copays disappear just as tax credits are reduced and premiums vary widely. This hurts people living in rural communities especially hard. Some would be expected to pay premiums in excess of their annual salaries. The changes proposed in the AHCA would be a radical cut to Americans and our American healthcare system and would result in unthinkable consequences for many. This at a time when, despite claims to the contrary, the CBO has indicated, as have other independent analysts like Standard & Poor's, that the ACA exchanges are stable after one-time premium increases this year. In fact, data just released from the 2017 enrollment shows the vast majority of exchange consumers' premiums were actually flat. This is not to suggest that the ACA doesn't have challenges, only that they should be worked on surgically. The American people expect us to keep improving what works and work together to fix what doesn't in an open and urgent manner. That's the direction we should take, and we can take as a country. Now, it's easy to get overwhelmed by the millions of people we're talking about displacing in this new proposal. For me and for many of us and many of you who have worked so hard to implement the Affordable Care Act across the country these last few years, each number represents a family and a set of voices we watched enroll, a letter we received telling us of a child's life saved, a home that wasn't foreclosed on, or an economic dream that was able to be pursued. All of us, no matter our politics, have a stake in making progress for these American families. Thank you.
Thank you very much, Mr. Slavitt. As I compute it, for the senior that you talked about, there is a 750% increase in their cost, from $1,700 to approximately $14,000 plus. Just extraordinary that somebody would think that they could still get insurance and still be covered. Thank you very much for your testimony. Former Congressman and Commissioner Kreidler.
Thank you, Whip Hoyer and Ranking Members Pallone and Scott for having me here today, and members of the Democratic Caucus. Let me say that the state of Washington, we fully implemented the Affordable Care Act. We expanded the Medicaid program. We created our own health insurance exchange. I didn't allow the older transition policies to continue, so they diluted the risk pool for the individual market. We saw a decline in the number of people who were uninsured coming from 14% down to 5.8%, or 410,000 people as to what it came down to. The individual market is thriving in the state of Washington. We have more carriers in the individual market today than we did before the Affordable Care Act. The rate increases that we've experienced have been much less than what we experienced before the Affordable Care Act. We have 150 plans and 13 insurers in the market. We're doing extremely well in the state of Washington. We did an economic analysis of the impact that Trump Care, the American Health Care Act, would have in the state of Washington, and I have to tell you, it's devastating. Not only the numbers that I just outlined here of where it goes from 5.8%, what we have today, would drive it up to 15%, which is 1.1 million people, and higher than it was before the Affordable Care Act. Our model modeled actual real people in the 2016 market and applied them then as if it went into effect immediately today as to what the Trump Care would have in the market. We modeled three important factors, one of them being the individual mandate, the income-based tax credits going to age-based tax credits, and also the 1.3 factor from the youngest to the oldest from the standpoint of age rating. Well, in our state, it would go from 1.3 to 1.375, which is embedded in Washington state law. Based on these changes, as I mentioned, we see the devastating impact on the number of uninsured, higher than it was before the Affordable Care Act. We also see that the young and older, lower and middle income people in rural areas are hit the hardest. People under the age of 30 and those between the ages of 50 and 64 are hard hit. People earning about $30,000 a year or below 250% of the federal poverty limit are by far the ones that are most seriously impacted. 81% of the people in our Medicaid program, 81% of those that, through the expansion of the Medicaid program, are at the federal poverty level or lower. Let me tell you, they're not going to go out and buy an individual policy. They can't afford it. It means that they go uninsured. And I'm extremely worried about that. Representative Scott mentioned what happened in the state of Washington in the 1990s. We wound up passing a comprehensive reform bill in 1993. In 1994, the Republicans took control. In 95, they repealed the mandate portion, but left in place the pre-existing condition protections. It was there in a partial fashion. It took 4 years, but the net result was by 1998, we'd collapsed the individual market in the state of Washington. You couldn't buy a policy in the state of Washington in 1998 or 99 because the market had totally collapsed, because you took away the mandate but left in place the pre-existing condition. Markets, insurance don't work that way. It took, as I said, 4 years, but it totally wound up then collapsing. To salvage the market, we came back with the insurers to create a high-risk pool. That high-risk pool was one where the insurers would be able to screen the individuals on a common factor, doing a survey that they could, so they referred into the high-risk pool. That was enough to be able then to get the insurers to come back into the market. The sad part of it, however, is that 80% of the people who were screened into the high-risk pool couldn't afford it. As a result of that, 80% did not get that insurance. It took the Affordable Care Act with its Medicaid expansion, premium assistance, for us to finally get our individual market straightened around. Please, we can't afford to go back to the way it was before. Thank you.
Thank you very much, Congressman. Now, let me introduce 5 members who have come in since I introduced the last group. Henry Cuellar from Texas, Lisa Blunt Rochester from Delaware, Kathy Castor, Judy Chu from California, and Darren Soto from Florida, and Jamie Raskin. I mentioned him twice. He's not from Minnesota, but he is from Maryland. Thank you for being here. I now want to recognize for questions and members. I apologize, but we're going to limit questions to 1 minute. And hopefully the answers will be relatively brief and pointed because I want as many members to be able to ask questions. We are now 5 minutes behind schedule, but that's not too bad. Diana DeGette. Diana DeGette, a member of the Energy and Commerce Committee and another key player in the adoption of the Affordable Care Act.
Thank you very much, Mr. Whip. So, Mr. Elmendorf, you said that what the voters thought during the election was that they weren't getting the insurance they wanted. Their premiums were too high and their deductibles were too high. So when they actually went in and tried to get insurance, they found out they had these very high deductibles and they couldn't get the health care they wanted. I'm wondering if you can talk briefly about what this bill, this whatever you want to call it, Trump Care, Ryan Care, what would that do to people's concerns about premiums being high? And also, what would that do? And I'm going to ask you, Mr. Slavitt, too, to answer this. What would that do to the kind of health care that people could actually get? You know, in our committee markup last week, and then Speaker Ryan, they keep saying, well, we're freeing people to be able to get the insurance they want because we're not going to have all these requirements and so on. What's that going to do to the deductibles, to the premiums, and also to the insurance that people can get?
Because of the relaxation of certain rules of the Affordable Care Act and other changes under this proposed legislation, CBO estimates that the out-of-pocket payments would increase substantially for people. Like other economists, I don't think that's entirely bad because it gives people more sensitivity to the cost of the care they're getting. However, it certainly means that we should not view a reduction in premiums for that reason as a sort of freebie that people are getting. Premiums are lower because people are paying more out of pocket. They can, on balance, be much worse off. So the change in premiums does not tell the whole story. We need to look at the change in out-of-pocket payments, and that would be a very sharp increase for some people under this legislation.
How about the deductibles?
Well, so this includes both the deductibles and co-payments.
Okay.
Could be substantially higher.
Mr. Slavitt?
Yeah, I think I would just echo this. When the actuarial value goes down, the deductibles have to go up. When they remove cost-sharing reduction estimates, the same thing happens. And look, I think we all remember what it was like back before the Affordable Care Act when people thought they had insurance, went in to get something covered, only to find out that their insurance company didn't cover it because it didn't have to. The ACA made that illegal. If we reverse that, we will not only have people paying more money, both in premiums and out of pocket, but also finding out when they get care that they're not going to have that covered.
Do you think this bill would have that result of reversing that?
I think that's absolutely the direction this bill would take us.
Thank you.
Ron Kind, Wisconsin, member of the Ways and Means Committee.
Thank you, and I want to thank Mr. Hoyer for setting up this hearing. As a member of the Ways and Means Committee, I think it's really borderline legislative malpractice that we're talking about a major piece of legislation that affects 1/5 of the entire U.S. economy and almost 1/2 of all federal spending, but without one hearing in Ways or Means or Energy and Commerce, and trying to ram this through on the American people. So we appreciate the chance to at least talk to you experts who've been living in this world now for some time to give us some feedback of what this country is getting itself into. One area I find a little bit amusing is Republicans with the recent CBO score have been taking a victory lap on the so-called $337 billion in deficit reduction over the next 10 years. But what it fails to recognize is the last CBO analysis we had with the Affordable Care Act last December. They were projecting a $355 billion deficit reduction under current law. So I don't know if kicking 24 million people off from health care and citing $337 billion in savings is something to crow about that much. But Mr. Elmendorf, let me ask you, I think everyone in America can agree that health care costs are just way too expensive. And that's where we need to be focused on. But there are a lot of things under the Affordable Care Act that was meant to address it, from delivery system reform, payment reform. Mr. Slavitt, you've been implementing a lot of the new alternative payment methods. Is there some progress being made as far as moving to a more value or quality or outcome-driven healthcare system under what was accomplished with the Affordable Care Act, and some hopeful news on that front?
Yes, progress is certainly being made, and the Affordable Care Act is helping, but there's a long, long way to go because this is a hard problem.
Mr. Slavitt?
Yes, just to give you one statistic, the per capita growth rate in Medicare costs under the Bush years was about 6%, and since the ACA, that's been 1.7%. So healthcare costs are too expensive. We need to take a bite out of prescription drug costs. We need to move to a more value-oriented system. Employers and government have been saying this for years, and consumers are saying they're feeling it in their pocketbook. No question about it. But we are making progress, and we need to keep going.
Again, this whole talk of death spiral, it's just devoid of reality. I mean, you look at per capita spending on healthcare overall, and it's at a 50-year low. Last year, Medicaid per capita spending was negative 1%. I mean, you just never saw that before. And you're right, there is more work that needs to be done, but there are a lot of things that are moving forward right now, and I'd hate to see this all reversed with this zeal to use Obamacare as a political punching bag. I yield back.
Thank you, Mr. Kine. It's critical that these facts come out, and the Republicans did not allow any witnesses to testify on the ramifications of their bill. That's what this hearing is about. Again, it's streaming live on resistrepeal.org and on my Facebook page. Next, Rick Larson.
Thank you, Whip Hoyer. Commissioner Kreidler, you took a red-eye flight here last night. This morning, I've done it before. While you're still fresh, I want to ask you a question. Don't ask anything after noon to Mike, knowing that experience. This gets to your experience as an insurance commissioner. Could you compare the ability of the individual mandate to keep or bring people in a pool versus the 30% tax for that the Republicans have proposed for folks who do not keep continuous coverage, and the likelihood of success of a 30% tax versus the alternative?
Clearly, having a financial penalty has a great deal more motivation. Unfortunately, the Affordable Care Act didn't have more of a financial penalty. And it was always one of the criticisms of the Affordable Care Act that there wasn't more. In 1993, when I was there with Representative Scott, we saw the Republicans introduce a bill identical to the Affordable Care Act that had a much stiffer penalty than what we have right now in the Affordable Care Act. So it works. But trying to go to something like a 30% penalty, you're only going to incentivize those that are younger and healthier in particular to sit it out and be prepared to pay the penalty once they become sick. If there's a diagnosis of cancer or multiple sclerosis or whatever it might be, they're going to jump over very quickly, pay the penalty, and it's going to be a minor impact. It means that they can be free riders in the system and then come in late in the game and come back. You don't have that with a financial penalty, particularly if it was a little bit stiffer than what we have right now. But even with what we have right now, we saw it work in Massachusetts, and I'm sure that you could see it work on a national basis, and in the state of Washington, where we've had phenomenal success already. Going to what the Republicans are proposing is obviously going to be one that will have much less of an impact, very negative, in fact, from the standpoint that you could see deterioration in the individual market as a result.
And just to follow up, it almost then follows that based on that analysis, there'd be more pressure, more price pressure on seniors or older Americans who, under the Republican plan, are already getting hit pretty hard based on how they want to distribute costs.
Absolutely. You deteriorate the quality of the risk pool. You wind up with more sick people, less of the healthy people, and insurance works pretty bad when you only have sick people in the market.
Thanks.
Essentially, what you're saying, am I correct? Not only seniors, but all people would have price pressure.
Absolutely.
And Thank you. Now, I'm going to recognize one of our freshman member, but I'm trying to go in terms of when people got here. Rajna Krishnamurthy, I spent 5 minutes every day figuring out how to pronounce his name. He's a great new member from the state of Illinois. Raja?
Thank you so much, Whip Hoyer. Thank you so much for having this hearing. I'm the ranking member on the Healthcare Subcommittee for Oversight, and we haven't had a single hearing on this, so thank you so much for organizing this. As you know, gentlemen, physicians have come out strongly against this particular bill. My wife's an anesthesiologist. The joke is that we both put people to sleep. So, in fact, her colleagues call the American Healthcare Act the AHA Act. AHA, we never knew healthcare was so complicated. But I had a couple quick questions. One is, I fear that this particular bill is a job-killing bill. Before this particular bill came out, the CBO basically estimated millions of jobs being lost from the repeal of the ACA. And given the Medicaid cuts, given all the other cuts, destabilizing state economies like Illinois and others, what do you see in terms of jobs being lost and our economy slowing down because of this particular bill? Dr. Elmendorf, could you address that?
Well, Congressman, as you know, CBO did not have time to analyze the economic effects of this legislation because this is a hard problem. And I think former CBO directors are wise not to try to reproduce a complicated CBO analysis out of their heads. So I don't know what the economic effects would be, but I will say, to be blunt, that the job-killing nature of healthcare reform is usually overstated. There are a lot of factors affecting the economy. Federal policy is obviously a very important one, but mostly what policy changes do is to shift around the nature of employment rather than change overall employment, and there are some exceptions to that. This bill may be an exception to that, but I think that should not actually be the primary consideration that you and your colleagues have.
Thank you very much. Next, Gene Green, Gene Green's left. Sandy Levin from Michigan.
Thank you, Steny, for holding this. Maybe it's good I come after Raja because I just want to quote what a doctor said who was picketing Senator Collins' office in February to bring this home. And as I read it, I'm reminded of what Speaker Ryan said. We always know you're never going to win a coverage beauty contest when it's free market versus government mandates. Here's the story very briefly that was told by that doctor in Maine. I know firsthand what the ACA does for families, a family medicine doctor. We found a decent plan through the insurance exchange, and then my wife was diagnosed with breast cancer. It was the worst time of our lives, absolutely agonizing. But amidst all the grimness we were facing, at least we had some measure of security, knowing that we had health insurance to largely cover her operations and chemotherapy. She got diagnosed and cured here in Maine, thanks to many terrific people and the ACA. So, Steny, as we approach these issues, I think we need to remind the Republicans what's at stake in terms of personal lives. Maybe this leaves you speechless, but if you want to comment, please do so.
Thank you, Congressman.
We did not invite these witnesses because we thought they would remain speechless. I want to tell everybody.
You know, I was, like many of you, in the position over the last couple of years to receive copies of letters sent to the president. I visited many enrollment centers, visited call centers, and the amount of people who were able to buy insurance for the first time in their lives was truly had a profound impact on me, including people who said things to the effect of, I realized the day after I bought my coverage that I had never had a good night's sleep in my entire life. And the next day, I was able to tell my daughter that she was able to play sports on the sports team in her school, finally. Those are the kinds of things that we hear about every day, and in the haste to pass this legislation, I worry that all of those people are just completely forgotten.
Thank you very much. Tulsi Gabbard. Tulsi still here? Kathy Castor, also a member of the Energy and Commerce Committee.
Well, thank you, Mr. Hoyer, for calling this hearing. I want to thank our witnesses for being here. Last week, when the Republicans released their bill on Monday night and gave us about 36 hours to digest this, it really took my breath away. It shocked the conscience, what is in here. Not just the $1 trillion shift in wealth to the wealthy on tax cuts, not just the fact that 24 million more Americans will be uninsured by 2026. The horrendous cuts to our neighbors who rely on Medicaid for their health services. These are children, the disabled, our neighbors with Alzheimer's, nursing, getting skilled nursing. And what was completely, really a bald-faced misrepresentation during the Energy and Commerce hearing. They said, there are no cuts to Medicaid in this bill. Yes, they actually said that. There are no cuts to Medicaid in this bill. And I think this is something, of course, that is kind of contemptuous of the American people. And if we had had hearings, it would have become apparent that this is the most radical rewrite to Medicaid since the health services under Medicaid were initiated. Would you all address that, or does this bill say there are no cuts to Medicaid? What is your view?
This bill has profound cuts to Medicaid.
Yes, the bill cuts Medicaid in ways that I think the governors that I have spoken to, I think, are either going to have to laugh or cry because they can't possibly imagine how to take 25% out of their program and keep it running. If we remember, Medicaid does some very simple things that Representative Castor, you just pointed out. Takes care of kids, takes care of people who live with disabilities, takes care of people in their last days in long-term care. There's not much more, and we recall now that 3/4 of Medicaid is controlled by managed care, which means it's largely capitated in cost. So not quite sure that there is any benefit, and there feels to me to be a great bit of harm.
Clearly, the Republicans are going to be looking at seeing the Medicaid program ratcheted down over time. States are going to struggle initially to try to keep the program in place, usually at the expense of providers, which means more providers will not take Medicaid because the reimbursement continues to fall. The states will struggle with it, but the net effect will be devastating from the standpoint of Medicaid program as we know it. It's only a matter of time till they stop the expansion of what they have and just go back to what was traditionally there. And even that is part of the Republican plan to radically rewrite the Medicaid program.
Can I just add an emphasis on that last point? Because this is not just taking away all that the Affordable Care Act did to Medicaid. It is going well beyond that and changing fundamentally the nature of Medicaid, the nature of benefits people will get. And the pressures on these governors will grow every year over time going forward. So the program will be just on a track to become less and less useful to people over time, well beyond taking back what happened in the Affordable Care Act and cutting deeply into what Medicaid was before the Affordable Care Act came along.
Thank you.
Thank you very much. Next, Henry Cuellar is left. Lisa Blunt, Rochester, from Delaware.
Thank you, Mr. Hoyer.
Now, again, let me caution people. We got to keep both questions. The panel's has been doing very well, by the way, on their answers, but we got to keep short because we need to end this in 10 minutes.
My question is very short, and it's along the lines of the previous question about Medicaid expansion. The question is, there are, I think, about 11 states, such as Delaware, that were early expansion states, and it's my understanding that we're going to see the cuts sooner than the other states. Can you talk a little bit about that?
The way the legislation would work is it first rolls back the higher payment rates to states under the Affordable Care Act, and that will particularly hit the states that undertook the Medicaid expansion.
So would it be immediate? Would it be next year? Would it be?
It will happen very quickly, but I don't remember the precise date.
Under state laws, there are 7 states where the Medicaid expansion will end immediately under their state law. Don Beyer.
Thank you, Mr. Speaker. Thank you for being here. This is incredibly important, your testimony. I have a very simple question. Let me quote President Trump, save Medicare, Medicaid, and Social Security without cuts. Have to do it. Secretary Tom Price, no one will be worse off financially. Speaker Paul Ryan, the Republican health care plan will leave no one worse off. Are any of these statements true? Are any of them based on alternative facts?
Those promises would be clearly contradicted by the passage of this legislation.
Yes, agree.
Don Beyer gets a star. The witnesses have been getting stars. I want you to know that. Judy Chu, member of the Ways and Means Committee.
Yes, Dr. Elmendorf, I participated in the 18-hour marathon hearing at Ways and Means on this act, and which we got, of course, with only 48 hours notice. But I am particularly concerned about the effect of this act on women. This act restricts the types of plans that can be purchased with a tax credit, even prohibiting plans that allow women to pay for abortion services with their own money. These restrictions are not only unnecessary because of the Hyde Amendment, but they effectively put abortion coverage out of reach of low-income and working women. What's more, the bill further restricts women's access to contraceptive care, which is so critical. And since the markup, the CBO estimated that due to the restrictions on funding Planned Parenthood, the bill would reduce access to the health care that helps women avert pregnancies. So Republicans have often cited, and in fact at this markup, they cited that redirecting funding to the community health centers in place of Planned Parenthood is a reason why women would not lose access to care. But in the report, CBO determined that defunding Planned Parenthood would result in up to 15% of current patients losing access to care. Can you walk us through the factors that CBO may have considered when coming to this determination?
Well, Congresswoman, as you know, I'm not at CBO now. I don't know what goes on inside CBO. I think you've characterized the situation very well. In general, people are getting health care through a particular avenue, and that avenue is cut off. It's quite hard to restore that in some other way, even if some money is going some other place in the healthcare system. So I think CBO's expectation that those women's access will be reduced is exactly right. But the particular factors that led to their quantitative estimate, I can't speak to.
Darren Soto from Florida.
Thank you, Whip Hoyer. President Trump had made 3 big promises. We're going to have insurance for everybody. They can expect to have great health care. It will be much simplified form, much less expensive, and much better. So can you tell us under Trump Care whether its promises kept or broken on coverage, on cost, and on quality?
Clearly, when it comes to cost, we're going to see the costs go up because the risk pool is going to be diluted considerably from the standpoint of having the younger, healthier, no longer facing a mandate, are going to wind up backing out. As that takes place, the risk pool becomes less well. It means that the cost for insurance continues to rise. As for the quality, it's hard to measure that because you're going to see fewer people with insurance, a significant increase in the number of uninsured. As a result of that, obviously, it means that it's harder for them. There are higher copays, deductibles that they're going to face, that there's going to be a movement more toward the very low actuarial value type bronze plans, even lower than what they are right now, that will become dominant in the market. So you wind up with, yes, you have access, but at the same time, it's the affordability is one that is seriously compromised, and it'll have a negative impact on quality along the way.
Now we're going to members that I have not introduced. Robin Kelly from Illinois.
Thank you, Mr. Whip. The Republicans say the CBO's estimate on the ACA was badly wrong, but now sometimes they like the CBO and sometimes they don't, but they estimate that it will reduce the cost of health care in the longer term. Do you agree with that? Or I know you spoke about who's going to be insured or not insured in the future, but do you agree with what they're saying?
The only reason why you would have lower costs is because you've driven people into catastrophic, very low actuarial type plans. That's very beneficial to, I shouldn't say that beneficial, but perhaps it's going to have some appeal to younger people, but it is devastating to older people, 50 to 64, who are going to be paying more for their insurance, but in many cases finding it's just plain unaffordable. So there's no way that you can look at this as being something that's for over time that is going to be, except for lowering it because of what you've done to the design of the plans, you've had a very negative impact.
And if I may, I know we're pressed for time, but I want to make a point about the work of the CBO under the ACA because I think it's being mischaracterized. So the CBO, what the CBO predicted for the could not predict, possibly predict when they evaluated the ACA was that the Supreme Court would come out with a ruling that would then cause governors in many states to not expand Medicaid. What they could not predict was that some in the Congress would defund the rate stabilization fund amounting to about $10 billion, which had the effect of closing co-ops and reducing competition. So the CBO never claims to have a crystal ball. What the CBO did quite accurately with the ACA was it said it's going to reduce the amount of uninsured to record levels. It's going to more than pay for itself, and it is right. And so even if in this case the CBO was off by as much as a third or more, it would not change the conclusion of the impact on the American public.
Thank you. Jamie Raskin.
First, one shall do no harm. Would you say this legislation passes the Hippocratic Oath or fails it?
It fails.
Yes, it fails.
Fails.
And have you ever seen healthcare legislation of this scope and dimension, either at the federal level or at the state level, undertaken without any hearings by professional expert witnesses?
Well, the period I lived through certainly involved a lot of hearings, Congressman.
Yeah, I'm not going to get the number exactly right, but the ACA had literally hundreds of open hearings, amendments, years, and input, and it would be beneficial if we could do that again.
Just briefly to recall the figures, 79 hearings in the House, 53 hearings in the Senate, 100 hours of hearings in the House, 181 witnesses in the House, 47 bipartisan hearings in addition to the 53. I won't go through all the statistics, but it was a full 2 years, essentially, a year and probably 10 months of hearings, witnesses, input, thousands of town meetings in one form or another. It was the most vetted piece of legislation I have seen in the 36 years I have been a member of Congress. Thank you. Marcy Kaptur of Ohio. And then, unfortunately, we're going to have to end questions there. The next panel, I would ask the members who have not had a question to save them for the next panel. Marcy Kaptur.
Thank you very much, Congressman Hoyer, for your excellent work as our Chief Whip. I wanted to ask any of the panelists who feel comfortable answering this question about insurance rates and what will happen to them for seniors and those between the ages of 50 and 64 in two areas. Number one, President Trump promised during the campaign there would be competitive bidding for pharmaceuticals in order to help lower prices. Do you find any evidence in this bill that that in fact will occur? And number two, in terms of rates, for single individuals between the ages of 50 and 64 under the ACA, they found that their prices under the ACA did go up with very high deductibles. They didn't have as many choices as they would wish, and the plans were expensive. Should they believe that Trump Care will actually lower their rates?
I know of nothing in the bill that addresses pharmaceuticals in the way you suggested, Congresswoman.
Isn't that a shame?
And it is clear that the bill would raise both the premiums and out-of-pocket costs like deductibles and co-payments for older Americans.
Thank you. Do you have any estimates or bands of estimates that you've seen on that second question for those over 50, what those rates might be?
Well, the Congressional Budget Office provided estimates for representative people. For example, for a single individual with an annual income of $26,500, the premium for a 64-year-old would rise from $1,700 to $14,600.
That's the 750% increase to which I referred.
And the deductibles and co-payments together would be more than twice as large as they are under current law.
Clearly, in the state of Washington, we modeled actual numbers, data, hard data, as to what we had in the 2016 market, and said what happens when you put it into effect if it happened today. And the people that were most adversely impacted were going to be those that are lower income or middle income, that either the young and the old are going to wind up being the ones that take by far the disproportionate amount of harm from the changes coming forth in Trump care.
I want to thank the three of you for spending time with us. It is hard for me to believe that had hearings been held, that the devastating adverse effects that you testified to in the American Health Care Act that is proposed by the Republicans, that if they'd heard this information, it is almost impossible for me to believe that responsibly they would have put forward the bill that is moving forward in the Budget Committee today. Thank you very, very much for your testimony. I now want to yield to Frank Pallone, the ranking member of the Energy and Commerce Committee, for the purpose of introducing our second panel.
Thank you, Mr. Hoyer. We can ask the second panel to come up at this point.
Which one? This one? Oh. Maybe we can match the tags to the people as opposed to the other way around. While we're doing that, I want to remind people again that this hearing is available to be viewed on resistrepeal.org. It is streaming live on that service. And in addition, it is streaming live on my Facebook page, so it can be accessed there. Frank Pallone.
Thank you, Mr. Whip. So the second panel will focus on patient and provider perspectives on the impacts of the Republican ACA repeal bill. And let me introduce the members who are here. First in the middle is Dr. Nitin Damle. I hope I'm pronouncing these properly. He is the president of the American College of Physicians, the nation's largest medical specialty organization with 148,000 members. He's also a clinical assistant professor of medicine at the Alpert Medical School of Brown University. Then we have Mr. Peter Burns as the chief executive officer of the ARC, the world's largest community-based organization of and for people with intellectual and developmental disabilities. He has served as the CEO of the ARC since July of 2008. We have Dr. Samuel Ross, who is the chief executive officer of, I'm going to say, Bon Secours, Baltimore Health System, and executive vice president of Bon Secours Health Systems, Inc., which owns the Baltimore Health System. They also own healthcare facilities in Kentucky, New York, South Carolina, Virginia, and Florida. And then we have Dr. Sam Zager, who is actually from my district originally, although he moved to Portland, Maine. I won't say much about that. He practices primary care at the nonprofit Martins Point Healthcare and also sees patients pro bono in a teen clinic operated by the federally qualified Health Center of Greater Portland Health. I would point out that he paid his own way, made his own way to get here today, and I appreciate you being here, Sam. And then we have Marta Connor, who is a mother to 7-year-old Caroline, who lives with Rett syndrome, The family relies on Medicaid for essential in-home services that keep Caroline alive and allow Marta and her husband to work outside the home. Thank you for being here today. So we're going to start with Dr. Damley.
Good morning, everybody. Thank you very much. I am the president of the American College of Physicians, and we're the nation's largest medical specialty organization. We represent 148,000 internal medicine physicians who specialize in primary and comprehensive care of adolescents and adults, internal medicine subspecialists, and medical students who are considering a career in internal medicine. So I want to start by thanking all the representatives and Whip Hoyer for inviting me to share my perspective on how changes in healthcare will affect patients. So I'm here today not to push really a partisan or political agenda. Rather, my sole reason for being here is that I'm a doctor who's deeply concerned that my patients and millions like them would be greatly harmed by the ACA repeal bill called the American Health Care Act. So let me explain. First, this bill will harm patients by taking coverage away from them. According to the Congressional Budget Office, the number of uninsured would skyrocket by 24 million Americans compared to the current law and 14 million next year. Without health insurance, people are less likely to have access to regular physicians, less likely to get cancer screening, tests, and vaccinations, less likely to keep up with their medications, more likely to get care in the emergency room, and more likely to wait to be treated until their disease has reached a more advanced and less treatable stage. I saw a 62-year-old male about 2 weeks ago who was relatively healthy but had a family history of heart disease. He came in with chest pressure and a change in his exercise tolerance over the previous month. I did an examination and an EKG and diagnosed him with a heart attack. He was taken by ambulance to the hospital where he was stabilized and subsidized yesterday, and he is doing well. He showed me his bill, $150,000. Fortunately, he had insurance, or he would have had to declare bankruptcy for medical expenses. Second, one of the reasons that patients will lose coverage is that the bill will make private health insurance unaffordable for older, sicker, and poorer patients. This is because the bill's age-based tax credits are too low and deductibles are too high for older and poorer patients, and because insurers would be allowed to charge older patients 5 times more for their coverage than younger people. The CBO found, for instance, that under this bill, a 64-year-old who makes $26,500 would pay $14,600 out of pocket for insurance in the non-group market, whereas under the ACA, it would have been $1,700, a 750% increase. Such patients simply can't afford to have more than half of their incomes go to buy insurance. Instead, they will just become uninsured. In my practice, I have many older, poorer, and sicker patients who would be left behind if this became law. Patients with diseases like congestive heart failure, diabetes, chronic obstructive pulmonary disease from smoking, who require frequent and ongoing monitoring of their medications, development of complications from their disease, and home-based nursing support. They often have unstable medical conditions put them at risk for falls and fractures at home, respiratory and cardiac failure needing hospitalizations, or dialysis from diabetes-related kidney failure. And many times they are on multiple high-priced medications. A patient of mine with hepatitis C infection is undergoing treatment that will cost over $90,000. Without insurance at an affordable price with reasonable deductibles, he and other patients of mine would not be able to afford care. My written statement includes a chart from the CBO that shows how the American Health Care Act makes health insurance unaffordable for those who need it most, the older, the sicker, and the poorer patients. Third, patients will be harmed by the American Health Care Act because it radically restructures and cuts Medicaid. It ends the promise made more than a half a century ago that the federal government will pay its fair share for states to help fund Medicaid, which today provides coverage to more than 70 million people, more than Medicare. Instead, it imposes a per-enrollee cap on the federal contribution to Medicaid. If actual costs to provide care exceed the cap, the states will be left holding the bag. The bill also would phase out federal funding to states, like my own state of Rhode Island, which expanded Medicaid to people with incomes up to 138% of the federal poverty level. The CBO found that because of these changes, the federal contribution to the states would be reduced by $880 billion over 10 years, a whopping 25% cut. With such reductions, states would have no choice but to limit eligibility and benefits or raise taxes, cut payments to hospitals and physicians, and cut other programs to make up for the shortfall. At least 14 million Medicaid enrollees would lose their coverage. I am greatly concerned about patients in my practice who would lose their Medicaid coverage as a result. I recently diagnosed colon cancer in a Medicaid patient. She will need to be seen by an oncologist, a radiation oncologist, a surgeon to treat her disease. With cuts in Medicaid, this patient will have difficulty accessing any of the above physicians and receiving hospital and outpatient care. Substance abuse, including opioids and alcohol, is a significant problem that we all know about, and Medicaid provides funding for treatment programs in our state and many others. With the proposed cuts, it will be difficult to support these patients and programs. So in conclusion, a first principle of medicine is do no harm. And the ACP believes that changes the American Health Care Act would make to our healthcare system would adversely impact tens of millions of patients, especially older, sicker, and poorer ones. So I sincerely hope that Congress will slow down the drive to pass this deeply flawed bill and instead work with ACP and others on bipartisan ways to improve current law without undermining essential coverage and consumer protections for millions of patients, as this proposal does.
Doctor, thank you for your testimony. You represent the largest specialty organization in America. Now, the AMA sent us a letter on March 7 stating the organization could not support the Republican legislation, quote, because of the decline in health insurance coverage and the potential harm it would cause vulnerable patient populations. Would it be correct to determine that your position and the AMA's position is the same?
Yeah, that is the same. I mean, we really both are opposed to it.
Thank you.
So the next person is Mr. Peter Burns.
Thank you, Whip Hoyer, ranking members and representatives, for convening this very important hearing today about the proposed legislation that would repeal the Affordable Care Act and pay for it by decimating Medicaid, a program that is critical to the lives of people with intellectual and developmental disabilities. The ARC is the largest national community-based nonprofit organization that advocates on behalf of and provides services and supports for people with intellectual and developmental disabilities through more than 650 state and local chapters nationwide. I'm here today standing on the shoulders of countless people with disabilities, their family members and friends, the professionals that support them, who have fought for more than 65 years to protect the civil rights of people with intellectual and developmental disabilities. We've come a long way in this country from a society that warehoused people in institutions to one in which people with intellectual and developmental disabilities are living, learning, volunteering, working, and doing so much more in their local communities. We are once again calling on Congress to protect their fundamental moral, civil, and constitutional rights to be fully included and actively participate in all aspects of American life. The ARC opposes the American Health Care Act because it would turn back the clock on 65 years of progress. Medicaid is the primary source of funding for the vast majority, 77%, of the supports and services that individuals with disabilities use to live in the community. These supports and services include help with meals, dressing, bathing, toileting, in-home skilled nursing, and communication support, just to name a few. These supports are critical to people with disabilities to be able to live their life in the community. In many cases, they can be the difference between life and death. Just this week, we spoke with a mom from Maryland whose 11-year-old daughter has Rett syndrome. And for years, she and her husband took turns staying up all night with their daughter, who required suctioning and other care around the clock just so she could keep breathing and stay alive. Medicaid provided a solution to this unsustainable situation. Through Medicaid, the family was able to get nighttime nursing care to keep their little girl alive, and mom and dad were able to have some peace of mind and get some sleep too. Families like this exist in every congressional delegation in every state in our nation. Unfortunately, and fearfully for these families and individuals, the proposed law would leave many people with disabilities and their families without health insurance to cover essential medical care. Even more troubling, it's unconscionable to use Medicaid program to pay for repeal of the ACA and to provide tax cuts for businesses and individuals that don't need them. The current proposal to implement a per capita cap on the federal government's investment in Medicaid, what I call cap and cut, will reduce federal spending on Medicaid by $880 billion over a decade. What this means for people with disabilities is that optional services like home and community-based supports will become scarce. And this will happen even though these programs have long enjoyed bipartisan support in Congress. Home and community-based services are discretionary for the states. And when they face billions of dollars in lost federal funding, that is where they're going to go to cut first. There will be limited availability of home and community-based services, fewer people eligible, reduced reimbursement rates for staffing, which will lead to poorer quality of care, and long waiting lists for services that already exist today are going to grow even longer. Medicaid's a lean program, and many states have already had to implement cuts both during and since the recession. So what else can they do to make up the difference in funding? Perversely, states will still be required to provide mandatory services such as institutional care. And we fear that states will return to outdated modes of serving people with disabilities, congregating large numbers of individuals in facilities with inadequate staffing and no real-life opportunities. Cap and cut will pave a path backward to institutional care and segregated services. I'd like to close by sharing how one dad in North Carolina put it when he heard what was being proposed in Congress. He said, and I quote, "I'm old, and I'm going to die in the next 5 years. My life's work has been to keep my son in the community in a meaningful way, to give him a life. Do you mean to tell me that I'm going to die, he's going to end up in an institution all alone, and what we built is for nothing?" We as a society have a responsibility to this older gentleman and his son. We cannot let our answer be yes, that's right. We cannot let the plans that he so carefully put in place for his son's future, which depend on Medicaid being there, to now unravel. And we cannot turn our back on the commitments we've made as a society to all the other families that have a loved one with intellectual or developmental disability. The ARC thanks you for shining a light on the concerns of people with disabilities who, as President Kennedy once remarked, are too often living in the shadows. This hearing is critically important because the catastrophe that cap and cut will wreak in the lives of people with intellectual and developmental disabilities and their families is not getting the attention it deserves. These proposed Medicaid cuts will be life-altering to children and adults with disabilities. They are morally reprehensible, and as a nation, we cannot allow this to happen. Thank you.
Thank you.
I just wanted to make a comment. You quoted John Kennedy, a quote that I use often when he was speaking to a group of parents of mentally disabled children. He said, although these children are the victims of fate, they shall not be the victims of our neglect. This bill represents neglect.
Thank you, Mr. Burns. So, Dr. Ross, you're up next.
Thank you. Good morning, Congressman Hoyer.
Morning.
Pallone, and other members of the Congress. Thank you for allowing us to be here this morning.
Congressman Scott, too, because he's a very powerful person as well.
Congressman Scott. Thank you again for allowing us to be here. And give voice to populations that have been voiceless for so many years, and particularly in our community. You already heard in my introduction, Bon Secours, but I'm also here as a representative of America's Essential Hospitals, where I serve on the board. A view from the front lines. Bon Secours serves a unique safety net role in our community. On average, 50% of our patients are covered by Medicaid. And in our Kentucky market, which I'm also the market leader, we also have a significant number of Medicaid. And for both of those communities, the Affordable Care Act allowed us to convert many uninsured patients to Medicaid coverage. So any changes to Medicaid would be devastating. So I'd like to focus on our Medicaid patients. First, the bill would eliminate enhanced federal matching for the Medicaid expansion. Expansion has been critical, covering nearly 250,000 people in Maryland and nearly 450,000 in Kentucky. Medicaid expansion has allowed Bon Secours, Baltimore, and Bon Secours, Kentucky to expand primary care and specialty care access, expand community outreach and population health initiatives, prevention and wellness that are essential for addressing the social determinants of health that impact our poor communities. While the bill would allow states to continue coverage for this population in the future, they would have to do so at the standard matching rate, an enormous cost shift to the states. I doubt that Maryland or Kentucky will be able to continue with the coverage expansion that we have experienced without some negative consequences. Ultimately, I expect that most of the currently covered by the expansion to become uninsured again. Certainly any confusion around enrollment process will only exacerbate gaps in coverage and be a major step back for low-income and vulnerable populations around the country. Second, the bill would establish per capita caps for all Medicaid beneficiaries. The combined impact of those two changes would cut Medicaid by nearly $900 billion over 10 years. This is unprecedented, this is unsustainable, and is unconscionable. Given these long-term cuts, states will have very limited ability to maintain their Medicaid programs. States would basically have three options in dealing with these long-term cuts. And unfortunately, those options are just about cuts. One, states could cut provider payment rates. Medicaid payments are already below the cost of care in most cases. And in our state in Kentucky, the Medicaid program pays providers only 80% of the cost of treating those patients. Such cuts will only lead to further gaps in access for our patients. Second, states could cut benefits, which already been mentioned. Like most states, Maryland and Kentucky currently cover several optional benefits or quote-unquote discretionary benefits that are critical to patients, including dental care, optometry, hospice services, mental health, and substance abuse treatment. And while some may view these as discretionary, in our population, we view them as essential because otherwise we can't improve their health. Finally, states could cut people off the Medicaid rolls, another cut. I believe all three of these things would be necessary in order to achieve the impact of this bill. Maryland operates a unique all-payer system, so changes in federal policy affect us differently than other states. The unprecedented cuts to Medicaid through the rollback of enhanced federal funding for Medicaid expansion and the long-term cuts under per capita caps will have an overwhelming impact on Maryland's finances and its Medicaid program. In Kentucky, a poorer state than Maryland, and one that saw a larger expansion, the cuts would likely be even more devastating. I'm happy to note that the bill would restore Medicaid disproportionate share hospital payments starting in 2020. These payments are currently scheduled to be cut substantially. While that additional support to our essential hospitals is important, it would be swamped by the substantially increased uncompensated care faced by hospitals like mine. In short, the ACA guts Medicaid as we know it. The cuts are unparalleled and would have disastrous impacts on our hospitals and patients. It's for these reasons that we're urging congressional leaders to withdraw this bill and work with stakeholders to craft new legislation that meets the needs of all people in our country. Thank you.
Thank you, Dr. Ross. And now we're going to go to Dr. Zager.
Thank you, Whip Hoyer, Congressman Pallone, Congressman Scott, and other committee members. It is a privilege to be here today as a patient advocate to speak up for millions of Americans who stand to lose if Speaker Ryan's American Health Care Act were to become law. I'm not here representing an organization. Rather, I hope to share just a few stories from the front line of American health care. These are not fictitious or composite stories, but I am changing a few key identifiers to preserve confidentiality. As a family physician at the nonprofit Martins Point Healthcare in Portland, Maine, I care for patients from all walks of life. Many obtain health insurance through the Affordable Care Act. One of them was a polite grandmother in her late 40s, who I'll call Angela. She came for the first time to my office for a general exam, and we got to know each other a bit. She told me she often sews clothes for her 6-year-old grandson, who she babysits, but it wasn't until 2 weeks later that Angela's principal health concern became clear. She was addicted to opiates, and she had shown up in our clinic a second time in withdrawal. After medically stabilizing her, Angela and I had a long, honest talk. She said that she had hidden her addiction for nearly 2 decades from her family and friends. That night, though, Angela went home and told her partner the truth. To her relief, he was supportive. And they went together to her first substance abuse counseling appointment. We also began buprenorphine naloxone, or Suboxone, therapy, and she started attending a 12-step support group. Angela told me subsequently, as I got more sober last week, I came more to terms with the damage from my addiction. I'd been making peace with the people I've hurt. Her grandson's father, it turned out, died from a drug overdose in 2010, and his mother, Angela's daughter, was still in the throes of her own addiction. In addition to buprenorphine treatment, we also continue to work on preventive measures that are central to primary care. Now, almost a year and a half later, her life is much more stable. She's planning to return to school. She's in the process of assuming custody of her grandson and looks forward to breaking the cycle of addiction in his generation. This renaissance began for Angela when she got insurance through the ACA. As a working-class woman, approaching 50, suffering from the mental health diagnosis of addiction, Angela is exactly the kind of American who could lose under the AHCA. And by extension, so would her grandson. Yesterday, I saw a 50-something-year-old man who I'll call Mike. Mike became my patient about the same time as Angela after he, too, gained insurance through the ACA marketplace. Like Angela, Mike is a hard worker. He told me he earns about $30,000 per year. I asked him how he thinks the AHCA might affect him. I'm going to get crushed, he said. Indeed, when I plugged his numbers into the Kaiser Family Foundation website, it calculated that Mike stands to lose 48% of his tax credits under Speaker Ryan's plan compared to the ACA. Much of my view of the ACA comes from listening to my patients. However, my visceral connection to the ACA stems from the most awful year in my family's life, as Representative Levin alluded to. In the 2-month interval between finishing my residency training and the start date of my employer-based coverage, my wife, Tracy, was diagnosed with stage 2 breast cancer. And I was told after an ultrasound that the lump that I'd been feeling in my leg might be cancer as well. Anyone who has been told those words understands the terror that follows. My tumor ended up being benign, but the year of surgeries and chemotherapy that Tracy endured was a grim and fearful time for our young daughters and us. In our weekly support group, we met families facing life-threatening illness, sometimes in the parents or caregivers, and sometimes in the children. A frequent theme of our weekly groups was how the specter of financial ruin compounded the terror of the disease itself. One measure of comfort for our own family was that we had health insurance from the ACA marketplace, again, during that gap period. Thank heavens, treatment went well. Tracy today is cured of her breast cancer and back to work supporting teachers in public schools. We are incredibly grateful to those who restored our health and also that we had health insurance. These are just a few of the many stories in which the ACA played a central role. In public debate in Congress, the actual people can be obscured by graphs and numbers. But ladies and gentlemen, every day in clinic, I am one-on-one with real people, real Americans who could take steps closer to health or suffer more from this Congress's decision. I urge you and your colleagues to reject the American Health Care Act and instead strengthen the Affordable Care Act. Thank you.
Thank you, Sam, if I can call you that. I really appreciate your testimony. And Marta Connor is next. Thank you so much also for being here. We appreciate it.
Thank you. Thank you, Whip Hoyer, Congressman Pallone, Congressman Neal, Congressman Scott, Leader Pelosi, and other members of Congress here today for holding this important hearing and for inviting me to testify. My name is Marta. That's my daughter, Caroline, and we live in Virginia. Caroline is 7 years old, but she can't walk, talk, use her hands, sit unassisted, or even chew her food because she has Rett syndrome, a neurological disorder that interferes with her ability to control her body and also causes a number of medical issues. Caroline is essentially trapped inside her body. But she is so smart and so full of life and so full of love. She's obsessed with Beauty and the Beast. She's thriving in school, and she really enjoys being with her friends. But Caroline actually didn't start showing symptoms until after she turned 1, when she wasn't walking or even crawling. But she was pretty healthy otherwise. She could say about a dozen words, and she could even feed herself. But around 14 months, she started having involuntary and constant hand movements, which is a hallmark of the disorder. She also started choking on her food. She could no longer get her words out, and she struggled to hold on to her toys, even though she was still desperately trying to hold on to them and play with them. Her hands stopped working almost overnight. My husband and I received the official diagnosis when Caroline was 17 months old, and we were stunned and we were devastated. But we promised her that we would live a happy and full life no matter what, and we want to keep that promise. I never imagined that I would have a daughter who would depend on us for every aspect of daily living for the rest of her life. And I certainly never imagined that I would have a daughter who would rely so much on a government program like Medicaid. But Caroline is the bravest person I know. She endures a level of discomfort and pain that is unimaginable to most of us in this room. She takes a total of 10 different medications several times a day to manage a long list of medical complications. She suffers from seizures, and she's susceptible to respiratory failure and pneumonia, which nearly took her life in the summer of 2015. So she needs to undergo a couple of hours of lung therapies every single day so that she can do something that we all take for granted, which is to breathe and to stay alive. And when she has a cold, which happens often, we have to administer these treatments almost non-stop, round the clock. So just to keep her out of the intensive care unit. So caring for Caroline is actually a full-time job, but Medicaid provides skilled nursing services, which allows us to raise Caroline in our home instead of having her in an institution or a hospital. This allows my husband and me to hold jobs and take care of other family needs. Medicaid also helps cover the cost of medical care and equipment that's not covered by our insurance, private insurance, and I should mention that I have really good private insurance. And these costs can add up to a few $1,000s each month. And because of the medical care that we're actually able to administer at home and the life-saving hospital-grade medical equipment that Medicaid helps cover, Caroline went from spending weeks in the ICU almost every time she caught a cold to just one hospitalization last year. So losing Medicaid services would be detrimental to our family. I'm not sure how my husband and I would be able to hold jobs. We would not be able to afford all of her medical care, which Caroline needs, and it would put her life at risk, and it would also decrease the quality of her life immediately. Our living situation would not be sustainable. We would be very stressed. So Medicaid not only helps keep Caroline alive, it allows us to function as a family and to continue to be productive tax-paying members of society. The House Republican plan for Medicaid would put my daughter's life at risk, and my family is terrified. We don't know how long we have with Caroline, but we want her to live with us in our home for as long as she's alive. We just want her to go to school like every other kid. We want our family to have some semblance of a normal life. We want our daughter to get what she needs so she can feel safe, be comfortable, and stay alive. Excuse me. The administration and Congress need to act in the interest of the country, and that includes every member of society. Children, people with disabilities, seniors, hardworking families who can't make ends meet, and other vulnerable populations. And Caroline's life is in your hands. So I ask you to please protect Medicaid. Thank you again for the opportunity to testify, and I would be happy to answer any questions that you may have.
To all the witnesses, thank you very, very much for giving your perspective on the consequences of the adoption or the repeal of the Affordable Care Act and the adoption of the American Health Care Act. The Budget Committee, some half an hour ago, after 45 minutes, passed the repeal of the Affordable Care Act. They did not have a single witness. The vote was 19-17. And in my view, they had the possibility of hearing your testimony and the testimony of the previous panel, they would have been a lot less likely to vote for a bill which has such adverse consequences on the very young, the very old, and everybody in between. Marta, I don't know whether you know this, but I served on the Labor Health Appropriations Committee for 23 years. One of the things that I'm proudest of, there was a little girl named Christy. She went to church with me. And like your daughter, for the first 18 months, she was normal. And then this neurological disorder arrested that growth and did what it did to Caroline. I put some money in the bill so that Baylor University and now with Johns Hopkins University and other universities could study this wrenching disease. Red, as you know, was a doctor in France who identified this syndrome. But thank you for your testimony. Because we tend to talk in general terms about big numbers, 14 million people, but we need to talk about Caroline. We need to talk about the individual. You talked about one of your patients. You talked about patients. You talked about your hospital and the ability to give service. You talked about those with disabilities. It is tragic that before the Republicans reported this bill out of the Energy and Commerce Committee, out of the Ways and Means Committee, and out of the Education and Labor Committee, and out of the Budget Committee, that they did not have a single person testify, both from a professional standpoint and from a patient standpoint and a provider standpoint, the consequences of their act. Let me yield now to Mr. Scott, who has a question.
Dr. Donnelly, you mentioned a cancer patient and the challenge they have going from one specialist to another, and what might happen if they lost their insurance coverage. What's wrong with utilizing the emergency room in this case as a safety net rather than having insurance?
That's a good question, and really the answer is that, first of all, the emergency room is not appropriate for most patients who don't have acute conditions that really have not resolved and been treated in some other setting. The emergency room is a high-cost center. It's probably one of the highest places to seek care in our healthcare system. A simple sore throat seen in the emergency room can cost $1,000. In an office setting, can cost less than $50. So it is not efficient to be seen in the emergency room. And a patient like this, the last thing they need to do is get care in the emergency. They need coordinated, team-based care that's going to coordinate their chemotherapy with their radiation therapy and having a good surgeon on board. And without that, they are going to do poorly, and they're going to end up in the emergency room with end-stage disease.
Chairman Crowley, we've been joined by the chairman of the Democratic Caucus, Congressman Crowley from New York.
Thank you to the whip for holding this hearing today. Despite the lack of attention from the Budget Committee, America is listening to what we're doing here today. And I thank you and the ranking members of the requisite committees and all my colleagues for being here today. I was unfortunately not here for the first three individuals who testified, but the last two struck me remarkably, and I asked my colleagues as to whether or not you gave similar testimony they said you had. A lot of promises have been made. We've promised to defend the Affordable Care Act, to improve the Affordable Care Act. Our Republican colleagues have promised to undermine it, and they've done a fairly good job of that so far, and to repeal it. The president, during his campaign, called it a very, very bad bill, a terrible law. Although we do notice that our Republican colleagues actually like certain aspects of some of the mandates that we have in the law, including keeping young people up to 26 years of age as a mandate in the law. That lifetime caps would be lifted is a mandate in the law. That individuals with pre-existing condition, Ms. Connor, your daughter, would be mandated never to lose her insurance. There's one mandate they don't like, or there's a number of mandates, but one in particular, the individual mandate to require individuals to purchase insurance. I just want to come back in terms of the rhetoric of the campaign. Those of you who have seen the effects, the positive aspects of the Affordable Care Act, Obamacare, and this may be more of a personal question, Ms. Carter, as well as Dr. Zager, and to all the panelists. How did that make you feel when you heard every day in this campaign how bad this law was, knowing that in many respects it's saved the life of your loved one, given an opportunity for your daughter, Ms. Connor, someday to maybe go to school, to have as much of a normal life as possible under your trying circumstances? Or Mr. Zager, Dr. Zager, your wife's prognosis and what has been afforded to her and to your family and to you because of the Affordable Care Act. The rhetoric that you heard, the hateful rhetoric towards this bill, and knowing the good that it's done, how'd that make you feel? And how do you feel about what's happening today? The 45-minute debate in the Budget Committee, the dismissal of every germane amendment in both the Energy and Commerce Committee as well as in the Ways and Means Committee, dismissal of some good thought and ideas as to how to improve the Affordable Care Act. How did you feel about that? Just if you could for a moment, give us your personal sense of what you've been going through. Yeah.
Sure.
Ms. Connor?
I felt like Carolyn was forgotten about. I felt like I was getting the message that she didn't matter. And I felt helpless. My husband and I feel helpless. And it's just frustrating to know that the Republican members of Congress are not behind us and that they're not serving every member of society, especially the most vulnerable ones. But I'm really thankful to know that I have y'all's support here. It means a lot to us and to the disability community.
Dr. Zager?
I would echo that. I think that what this is really about is how we see ourselves as a community within our nation, but also as with our local neighbors. Do we take care of each other, knowing that, not knowing when we ourselves will be the vulnerable ones, the terrified ones? So I think it has a lot to do with how we see ourselves and what kind of a nation we want to have.
And thank you both and all of you for your testimony. We'll let you know that we're here. We understand it. We get it. And that's why we're defending this. We want to improve affordable care in this country, not dismantle it. Once again, I want to thank Whip Hoyer for your leadership here this morning, for all of your testimony today. Thank you, and God bless you all.
Thank you very much, Chairman Crowley. I'm going to recognize Sherry Bustos from Illinois, and I want to Peter Welch, Bonnie Watson-Coleman, Bill Foster of Illinois, Ed Perlmutter of Colorado, Luke Correa of California, and Brad Schneider of Illinois. I'm sorry, didn't I say Jackie Rosen? I should have said Jackie Rosen after Peter Welch. Excuse me. And we've also been joined by the person who probably has demonstrated during the course of his life, Maria, more care for the American people than perhaps any of the rest of us. We've been joined by the Senior Chief Deputy Whip, John Lewis of Georgia. John, thank you for joining us, sir. All right, Sherry Bustos.
All right. Marta and Sam, just something that came to mind for me when you were telling the stories is just, nobody chooses to get Rett syndrome or to get cancer. And these are the stories, and you're personalizing this, that we are hearing all over the country when we do our town halls. We're having hundreds of people show up about this. And I think the common denominator, nobody chooses to be sick. My brother didn't choose to get cancer and have cancer take his life. Poor Caroline going through this Rett syndrome and living in pain. And so I think that's the story. And I appreciate Congressman Crowley pointing that out, that it's not as much about the numbers as it is about the human being. So thank you for sharing that. My question, though, is for Dr. Ross. I'd like to drill down a little bit. I have a rural district in the state of Illinois. I represent the entire northwest corner. It's rural, and Donald Trump won it. So I'm in the state of Illinois. My colleague here next to me, Brad Schneider, is in the Chicago area. All of the Democrats in the state of Illinois are in the Chicago area except for me. So I'm kind of a blue island in a sea of red. But I just bring that up because the people in my congressional district supported Donald Trump, by enough numbers that he won my congressional district. But I'm concerned about a rural district like mine and what that's going to do. Rural hospitals are among the largest employers in all the counties where we have these hospitals. We have about 6 rural hospitals. And I'm wondering about the economics of that. What's going to happen to these rural clinics? What's going to happen to the rural hospitals? And I'm being told that they could go out of business. And then wondering on the other side of that, what happens to the patients in those rural counties that they get the care from these hospitals that likely will struggle financially? But I'd love to hear your perspective on that, since Bon Secours has, I know, at least one rural hospital, and you can relate to a district like mine.
All right. Thank you for the question. I mean, we're very concerned because, as I mentioned about Kentucky now, if they're only getting 80% of their costs covered by the Medicaid reimbursement, further cuts is going to make that even worse. And the deeper those cuts go, we have to look at what programs we cut, what services we cut, employment issues that will follow, and then there are access issues that will follow. Because what we know is a lot of people don't have clinics close to them. A lot of people don't have hospitals close to them. And so it'll make delayed care, deferred maintenance, people with chronic conditions, specialty issues, have worse conditions for their care. So our biggest issue, our biggest concern is that as we see reductions and further cuts, that we'll see reductions in programs, reductions in services, ultimately reductions in the number of people that we will employ because we don't have the resources, the revenue to do that as well. And we'll see increases in health disparities. And that's both an inner city issue and a rural issue as well.
Just one quick follow-up. Would you foresee rural hospitals having to go out of business as a result of what you know that is in this Washington Republican plan for their Health Care Act?
Our concern is that rural hospitals could go out of business and urban hospitals that are serving poor, indigent patients being impacted as well.
Thank you, Dr. Ross.
Thank you.
Thank you very much. Jackie Rosen from Nevada.
Thank you, Whip Hoyer. I want to give my deep thanks to, like I said, Whip Hoyer and the panel before for giving your heartfelt testimony. I'm the wife of a physician, so many of our friends are physicians, nurses, healthcare providers. So around my kitchen table for the last 25 years at holiday gatherings, events with our families, I have heard the heartbreak that physicians have about their patients and their families just like you do, and I appreciate what you're doing. As a former caregiver of my parents and in-laws, I also appreciate it on a personal level. So I want to talk about what happens. We have the most vulnerable. In my district, I have almost 90,000 people between the ages of 50 and 64. So what's going to happen with their new insurance plan is that the rates are going to go up 5 times greater than that of a younger person. And so especially, it's going to be hurt the 44,000 households in my district that make less than $26,000 between this age range. What will happen to those people when they can neither afford insurance, when they can't get Medicaid, and really what happens to the caregivers who help provide for them?
So,
Doctor.
Yeah, so I would say, you know, that age group, the 50 to 64, is a vulnerable population. That's when people start to get sick. They start to have illnesses, either acute or chronic. They need to start being screened for colon cancer, for breast cancer, for prostate cancer, and they will not be able to seek those services because they will not be insured. They will not be able to afford a physician visit or any further testing that they may need, like a colonoscopy to screen for colon cancer. And so they will forego all those services, and then 5 years, 10 years down the road, they will have later stage disease, or they will have complications of some other medical problem, diabetes or a heart condition or lung problems. So this is very serious consequences of not being insured in that particular patient population.
So in essence, what you're saying is we're kicking the can down the road as far as expense goes, because by not providing care now, we're surely going to pay with it, not just in cost, but in people's lives.
Well, then when they get to their Medicare age, then you're going to start to pay for it in Medicare expenses, which we all know are also very high and out of control.
And in the bill, essential benefits are eliminated for Medicaid, as I understand it. Next, Peter Welch from Vermont.
Thank you very much. Thank you. It must be kind of mystifying to see the way we operate around here. It'd be like you had a board meeting and no one told you that the topic was this gigantic multi-billion-dollar takeover or dissolution, and you showed up and sat in your chair for 27 straight hours, which is what the members of the Energy and Commerce Committee did. So basically, we need you and your local leadership in your institutions to guide us back to the light. Dr. Ross, can you just outline some of the positive things, and if there are some negative things in your work since the Affordable Care Act was passed?
Well, positive thing has been access to care. As I mentioned, in Baltimore, we had a significant percentage of uninsured. Our conversion rate under the Affordable Care Act was not the commercial plans. It really was our population that had previously been uninsured to Medicaid. And we saw about a 30% conversion rate in that population.
All right, so one of the mystifying things around here is a lot of folks think that if people didn't have Medicaid, we went back to the old days and they could just show up at the emergency room, which a lot of people did, that it would be fine. But in your experience, is it the case that a lot of people who have real illness and should see a doctor don't because they're embarrassed that they don't have health care that can pay for it?
A lot of them don't understand, as my colleague said earlier, the importance of having primary care and coordination of their care. So they only show up at the emergency room in the very late stages of any kind of chronic disease, hypertension, heart disease, diabetes, cancer, you name it. So having more access and awareness of prevention and wellness services really does reduce costs and improves quality of life over time.
Thank you. And Dr. Demley, how about you? What would you say is better, and if anything, what do you say is worse as a result of the passage and implementation of the Affordable Care Act?
Certainly, number one is access. I think that there's been a significant increase in the number of patients that can now be seen, and we're seeing that in our offices. We've had to hire more nurse practitioners and other physicians in order to cover the number of patients that are now coming in that did not come in before. So we have great opportunity to practice preventive health and prevent disease. We have seen some movement in terms of prescription drug costs. I mean, trying to control those to some degree through the Affordable Care Act. I think that's important. We have still a long way to go. And there are some innovative models that have been put into place in terms of transferring medicine from just a fee-for-service type of profession to a quality-based payment system.
So this is important because,
yes,
in my view, is that in order to maintain access, we've actually got to bring the cost of healthcare down. There's more to be done. Is it your view that if we pass this House bill, the Trump bill, that it will help to reduce the cost of health care, do nothing about it, or actually increase the cost?
Well, I think it'll probably, if nothing, it'll probably increase the cost of health care because, again, you lose access. And when you lose access, you lose opportunity. And opportunity is everything as far as medicine is concerned. So absolutely. And it will do nothing to drive down the cost of health care because it doesn't address any of the issues around the cost of health care.
Right. Thank you.
The cost of prescription drugs and the costs of testing, of imaging, of surgeries, of hospital stays, all of those things need to be addressed. They're not addressed in this bill.
Thank you. And my last comment, I just want to say to Ms. Connor, thank you. You know, it's so inspiring to hear from a parent who loves her child, as that child is, and carries on. But it's so reassuring that you've got enough help that you and your husband can live your life and love your child. So thank you for bringing that to us. Thank you.
Thank you. Bonnie Watson-Coleman from New Jersey.
Thank you. I want to thank you for conducting this hearing so that the people across this country can really understand the impact of what's before us and the devastation that it can wreak on so many different kinds of communities. And Ms. Connor, thank you so much for sharing your personal story. And for you, Dr. Zager, I know firsthand I've been a caregiver. My father, my aunt, they lived their lives out through my house. They had all kinds of services. They had good insurance. They were very fortunate. So I know how important it is to be able to make your loved ones comfortable as they go through their illnesses. I also know what it's like to be in the state of New Jersey, in which a number of hospitals have closed, Dr. Ross. A lot of those were our safety net hospitals, which has foreclosed the access to people in most need. And I am very concerned about the impact of this bill on those safety net hospitals, where people who already have limited access to hospitals, what will this mean to those hospitals that have been sort of inundated with the uncompensated care communities? Doesn't that just thrust more on them? Doesn't that make it more difficult for them to even to survive and to provide the services? And will we continue to lose hospitals as a result of this?
We'll definitely continue to lose them. My colleague from the association just gave me, this information. Becker's Hospital Review found that 16 of the 21 hospitals that closed in 2016 were in states that did not expand Medicaid. And most of those were rural hospitals, which Representative Castro asked about. Essentially, to have a mandate as a safety net hospital and not have the funding puts us in the situation that you just described, that our expenses continue to rise and our revenue continues to either stay flat or decrease. Most of these patients, if they come to our emergency rooms because of the EMTALA, we can't turn them away. We have to do at least a medical assessment, but by the time you do the medical assessment, the screening, the testing, you've already incurred significant expenses. So we'll continue to see our expenses grow without an associated increase in our revenue, which puts us at risk as safety nets of really unable to balance our books, unable to keep our doors open, unable to expand programs and services.
I think it's really important that our communities understand that you can be rural or you can be urban. If you're not some specialized hospital, some big teaching hospital, you really stand a chance of not being able to serve the population that is most in need because of this bill. And that's so much a reason for us to fight back. And I thank you, Mr. Hoyer, for giving us this opportunity to air some of these issues. And thank to all of you for sharing your stories and your assessment of the impact of this bill.
Perlmutter from Colorado. Ed Perlmutter.
Thanks, Mr. Hoyer. And the longer I sit here, the madder I get, because it's clear whether it's the provider or the patient, the hospital, it's less coverage and more expense. And you say, why? I mean, why do that? You know, there's a lot of money going in big tax refunds, and there are 15 to 20 million people who are going to lose their coverage. And the whole thing is so backwards and so wrong. I mean, it's sort of class warfare, and it ain't right. So your story, Ms. Connor, your family's, sort of survival on this thing is at the heart of this. Individual by individual, there is a big difference in finances, big difference in emotional well-being, big difference in a lot of ways. And my guess is everybody on this panel knows somebody like you. So, Dr. Domley, I missed your testimony, and I apologize for that. But how do you see this thing? Why reverse all of this? I mean, can you put yourselves in the position of the sponsors of this new bill? I mean, why do this?
From a medical standpoint, there really is really no reason to do this, because the Affordable Care Act needs improvement. But for the most part, it has worked, and it has insured 20 million people that were not insured before. So why go back in time and again create this access problem for us now? And it doesn't address, as I mentioned earlier, the issue of cost. It would be one thing if they were able to come up with a program where cost was addressed and they could show that they could lower premiums for everybody, cover more people, and provide better care. But they haven't shown any of that.
Well, and that's what the president said. I'm going to have more coverage. It's going to be better care.
Everybody.
Costs are going to go down. And what we see is it's just the opposite. It's all talk. But once you put the pen to the paper and you have some action, it's just the opposite. And, I think everybody in the country should be worried. Dr. Zager, you were talking about, is it the rich for themselves and everybody else be damned? Or are we in this together because somebody in the family is going to get sick? And, you had it, young couple, you guys probably both strong as oxes, and all of a sudden one day your world is turned upside down.
Congressman Perlmutter, thank you very much for highlighting those important aspects. I think it's important to underline that bad things happen to good people. I think a lot of the philosophy that underlies the AHCA is personal responsibility, and the notion is that illness is a moral failure, and I fundamentally reject that. It's a moral or a failure of responsibility. And so I fundamentally reject that, and that's a large part of why I reject the AHCA. There's things that can be improved, certainly, about the ACA. Everyone's in agreement about that. But I think that we should work on improvement and enhancing what that is, the tremendous leap forward that the ACA brought us 8 years ago.
Dr. Zager, thank you for that comment. Thank you. And I will say that we have been prepared since we adopted this bill in 2010 to do exactly that, to make it work better. Not to decimate it, but to make it work better, make access better, make quality better, make affordability better. We have been unable in the last 6+ years to engage beyond simply repealing the Affordable Care Act with no replacement. Now they've come up with a replacement, but have had no hearings, no witnesses, and no CBO score before they marked it up. It is really very, very unfortunate. And the American people ought to be very disappointed with the kinds of process that we're going through, and certainly with the policy that is being suggested. Now I want to yield to my dear, dear friend, for whom I have so much respect and love, John Lewis of Georgia.
Well, thank you very much, Mr. Hoyer. I want to apologize for coming in late. He had an appointment off the hill,
yep.
But I'm happy to be here.
Glad you came.
I want to ask you, do you consider the Republican health bill mean spirit in light of we're cutting CDC, EPA? My philosophy is very simple. We have a right to know what is in the water we drink, what is in the food we eat, what is in the air we breathe. This bill is rewarding those at the very top, the millionaires, the middle class, low income, must fend for themselves. I'd just like to get some general response. I'm sorry I missed your testimony.
Mr. Burns.
Thank you. Congressman Lewis, the adoption of the Affordable Care Act was perhaps one of the most important developments in law for the rights of people with disabilities in at least the last 25 years, since the Americans with Disabilities Act.
I was glad you said that.
And there have been many major milestones in the evolution of rights of people with disabilities over the last 65 years. And this current legislative proposal is an attack on everything that has been accomplished for some of the most vulnerable people in our society, and we have to call it exactly what it is.
Does anybody else want to comment on that quickly?
Yes,
Doctor?
but I would say that healthcare really is a fundamental human right, and that's something that the Republicans, I think, are not accepting. They feel the choice is more important, that people ought to be given the choice to have insurance or not. That's a specious argument. You cannot go without health insurance, and you cannot make insurance so expensive that no one can afford it. So you are putting a lot of people at risk. And finally, I would say this anti-science movement is really critical. Reducing funding to EPA, reducing funding to NIH, reducing funding to National Science Foundation, all is going to hurt us in the long run, because science is the basis of what we have today as a society. So it's very important that we fund these adequately.
Mr. Snyder.
Thank you. And
Brad Snyder from Illinois.
Thank you. I want to thank Mr. Hoyer for arranging this hearing. Thank you to the witnesses for making your time available and sharing your insights, experiences. I can't tell you how important it is for us to hear from you. I have so many questions, obviously not enough time. The Affordable Care Act, as I think has already been said, no one said it was perfect, but it was a great step forward. And we've been talking about the need to build on the great successes of access, of extending healthcare to more people, addressing the challenges and continuing to move forward. My feeling is that what has been proposed, the ACA, shrinks on the successes, addresses none of the challenges, and instead takes us in a great step backwards. There are so many issues. Dr. Zeger, I'm going to turn to you to start, because one of the things this bill does is cut funding for Planned Parenthood, cuts funding for women's health. What impact, short and long term, do you see that reduction in funding for women's health in general is likely to have on communities like yours, communities across the country?
Thank you, Congressman Snyder. I appreciate your question, and I think I would respond by saying that women's health includes many things that is involved in the health of us all, but many things, obviously, that are specific to women. Some people consider contraception a women's issue. Prenatal care, which is one of the most evidence-based things that we can do to improve the health of populations, cost-effective, it improves outcomes, and a lot of, when women get shunted away or turned away from the healthcare system through things like provisions in the AHCA, we all suffer. It's our children, it's women, and in essence, all of us. And so I think that it's terrifying to consider the ramifications for women's health if the AHC would be passed.
Does anybody else want to comment on that?
Well, I mean, Planned Parenthood is an essential component of women's care. It provides, most of its services are really preventive services. They screen for sexually transmitted diseases. They provide contraception. We know that 50% of pregnancies in the United States are unplanned. I mean, these are important issues. They give counseling to patients, both in terms of health risk and also in terms of providing even psychological help for certain patients. So it's an essential service that millions of women are going to now be at risk for losing.
Thank you.
Thank you. And
Brad, one more question.
Just to close quickly, as you talked about, we're cutting funds at prenatal care, creating gaps and risks. Dr. Donnell, you talked about the fact that we're making it more expensive, often impossible for people between 50 and 64 to get the health care at the time when they need that screening care probably more than at any time, putting people into emergency rooms at our safety net hospitals, the worst place to get the care at times, most expensive, least effective, certainly for preventive. I can't speak to whether this was mean-spirited or not. I can't look into the hearts of my colleagues. But I think what I'm hearing from the panel is this is short-sighted. The denial of science is putting us at a place where we're going to be spending far more than we otherwise would have to on healthcare in general. And in particular, and I'll close with this, in my community, communities across the country, we're seeing a spike in opioid addiction and the cost to our communities of addiction and deaths. If any of you can touch briefly the impact of cuts to Medicaid might have on the treatment of addiction, not as a failure of spirit or morality, but as a disease, something that can be treated and dealt with as a chronic disease.
I'm not sure if you were in the room at the time, Representative Snyder, but I'm a Suboxone prescriber. I'm relatively familiar with the epidemic that we have in Maine and nationwide. Opioid addiction, as with a lot of addictions, has implications, ramifications across across our communities. It affects whether people will continue school. It affects whether people will be able to function as caregivers, whether they'll be able to essentially live fruitful lives, which is arguably the purpose of health care or health, is to enable people to live the lives that they should live. But we also it's a classic thing to cut, and it's also a classic thing to show the short-sightedness when you want to save a little bit of money in the short term and ignore the long-term consequences. Then that's obviously bad policy.
Thank you so much, Whip Hoyer, and all the leadership for holding this hearing, and thank you all for being here and for your testimony. Just to follow up briefly on Mr. Schneider's first question, Monday I was out at an AFQHC in Oregon, one of the 6 Virginia Garcia clinics, named after Virginia Garcia, 6-year-old daughter of a migrant worker who died from an infection because she had no access to health care. And they're doing great work with a series of clinics now out in Oregon, and I asked them the question, could you absorb the caseload if Planned Parenthood lost its funding? And they're already bursting at the seams. I mean, doing great work, but they can't absorb the work that Planned Parenthood is doing. And I'm extremely concerned about those cuts to Planned Parenthood that are proposed. But I want to ask Mr. Burns a question. Oregon has taken advantage of the ACA's K-Street plan, state plan, option to provide home and community-based long-term care services. The state receives a 6% federal match on funds through that program, assisting in my district, the 1st District of Oregon, 5,248 constituents. as well as in the 2nd Congressional District, next to mine, 7,049 individuals. That's the district represented by my colleague, Congressman Greg Walden, who is chairman of the Energy and Commerce Committee that, despite holding no hearings on the legislation, recently marked up the ACA repeal bill that would end this federal match. So, Mr. Burns, can you describe what some of the effects might be if this K-State plan, particularly for the 40,000 elderly and disabled individuals in Oregon and the hundreds of thousands more across the country who rely on long-term care, how would they be affected?
For that question, you're referring to a provision within the Affordable Care Act that's called the Community First Choice option. And the intent behind it was to let folks with disabilities, support individuals with disabilities to live in the community rather than in institutions. And that was an option to states, and your state is one of only 8 in the country that have had the wisdom to pursue that option and really significantly enhance their commitment to supporting people living in the community. The AHCA will take that all away, and we feel the result of that is going to be that more individuals, if they receive services at all, will be served in institutions. They'll be cut and they'll be cut out of their communities, and their qualities of life will suffer as a result of that.
And will that be more or less expensive?
Oh, the cost of institutional care is way more expensive than the cost of supporting people with disabilities or people who are elderly to live in their own homes and communities.
So in addition to removing people from their community, it's also going to be more expensive.
Absolutely.
So I just want to mention, too, that Oregon has really embraced Medicaid expansion. We have really functioning coordinated care organizations around the state that are doing amazing work, coordinating care, focusing on prevention, working with mental health care, dental care, vision care, primary care, working with early childhood education, for example, and really seeing great effects in the local communities. We are extremely concerned about what would happen if Medicaid is changed, if it's block granted, and the changes that would happen to Oregonians and people across the country. So again, thank you so much for your testimony. I have reviewed your testimony. I was in another important hearing, but I really appreciate all of you being here. And I know I join my colleagues here in saying that we need to do all we can to make the Affordable Care Act work better, but definitely not get rid of it. And thank you again for holding the hearing, and I yield back.
Thank you very much, Congressman. Congressman Jim Langevin from Rhode Island.
Thank you, Mr. Hoyer. I want to thank you, first of all, for organizing this hearing, and I want to thank our witnesses for being here this morning. This is an important perspective for all of us to hear. And by the way, the type of hearing that quite frankly should be held by our Republican colleagues as they're tackling and trying to change one of the most pressing and serious domestic policy challenges that we have as a country. So I thank you all for being here. I particularly, of course, like to acknowledge Dr. Donnelly for being here today. He not only provides astute physician perspective for the panel today, but he also happens to come from Rhode Island. So, Dr. Donnelly, great to see you again. He also runs an internal medicine facility in my district. So I thank you for being here and for representing the Ocean State here at the panel. Dr. Donnelly, much of the paradigm shift in healthcare has been a focus on value over volume, accountable care, and consideration of the patient experience when approaching care delivery. So the Affordable Care Act is a foundational piece of legislation that began to drive an improvement of health outcomes by expanding access to 20 million Americans, 100,000, by the way, which live in our Rhode Islanders, by covering preventative service in an effort to identify and treat conditions before they become chronic. Obviously, we're making the early upfront investments. The hope is, the goal is, and believe is that we will prevent those more serious problems from occurring in the first place at later stages when potentially hospitalization or more expensive treatments would have been necessary. So focusing on that early preventative care, and also by providing state flexibility to expand Medicaid, and a provision that has allowed 75,000 Rhode Islanders to receive crucial healthcare services. And by the way, Rhode Island has one of the lowest uninsured rates in the country right now, in the single digits. The ACA also paved the way for Congress to tackle physician payment reform and make a vital investment in new treatments under the 21st Century Cures Act. Yet without health insurance, Americans cannot benefit from the systemic changes in care delivery nor breakthrough treatments of tomorrow, let alone the services that they require and that you perform today. So my question for you, and showing that I'd welcome the panel to chime in as well, can you please describe how the Republicans' ACA repeal bill which seeks to roll back Medicaid, remove the essential health benefits package for Medicaid plans, and create a penalty for non-continuous coverage, will impact continuity of care, your ability to develop a doctor-patient relationship, and overall healthcare outcomes for some of the most vulnerable populations?
Thank you, Representative Landry. Nice to see you. Yeah, really the Medicaid expansion, and Rhode Island was a state that adopted it, really allowed patients, again, access to seeking care that they normally would not be able to get. And whether it's preventive care or acute care, they're going to lose all of that, and they're going to be left vulnerable to showing up again in the emergency room without any insurance at all. The transition from the pure fee-for-service-based payment system to a more quality-based payment system for providers is, I think, really important. And that came out of the Innovation Center, and that was part of the Affordable Care Act. And that needs to really be recognized as something that's a real shift, a paradigm shift in the way that patients are taken care of. We really deal more with clinical teams than we ever have. We have people who are pharmacists and nurse practitioners and other allied health professionals help us in taking care of these patients, whether they're Medicaid patients or others in general. So that's a very important piece of the legislation that really needs to be recognized and needs to be retained. But without the adequate funding from the federal government, the state really can't afford to even continue some of the programs that it has. In terms of opioid programs, it really can't afford to continue those if Medicaid funding is cut. We have a budget that we need to balance, and we can't really do it on the back of Medicaid funding.
Thank you. Anyone else care to give a perspective? If not, I'll give back.
Thank you very much. Last question, and then a few comments from our ranking members. Brenda Lawrence, former mayor from Michigan, a new member, but a very, very experienced member.
Thank you so much. Thank you to our leadership here for having this very important meeting. There's been a lot of discussion about the CBO, about the rating and whether the score is appropriate or inclusive enough to be used as a guide. I wanted to ask if the members here on the panel have any input on, have you used the CBO in the past, and where does it play in this whole discussion we're having on ACA?
It's absolutely essential for us in terms of policy development. The American College of Physicians is very much an evidence-based organization. We're very nuanced in what we say, and we don't make statements unless they're backed by fact. And we look to the CBO as providing us with accurate facts. They're nonpartisan, and they do provide us with important information going forward. They may not always be accurate, but even if they're off by even 10 or 15%, it still gives us a good sense of where things, how things are and where things need to go. So we absolutely rely on them.
Congressman, if you'd yield a second, let me say, you weren't here for the beginning of the hearing, but Doug Elmendorf was here, and Doug Elmendorf, who is appointed by Democrats in 2009 as director of CBO, and the present director of the CBO, appointed by Republicans, agree. Now, the discrepancies which the Republicans are pointing to in terms of hypothesis on how many people would be insured have largely been, under the Affordable Care Act, has largely been affected by, one, they misjudged how many employers would keep their insurance. They thought more people would lose their employer insurance than in fact did. And secondly, when the Supreme Court said that additional Medicaid was optional to the states, and many states did not add them, obviously those folks became uninsured. So that, frankly, there were extrinsic reasons beyond what the CBO knew at the time they made so they were pretty accurate. You yield back.
Thank you. My last question is about rural areas in America. The Kaiser Family Foundation stated that the rural areas, the expense of providing health care in those areas. I would like comments from you on the new plan as we see it and the impact, the model for premium tax credit. How does it address the geographic challenges in health care?
I don't know. We're doing it now. I'm with America's Essential Hospitals. Even though I'm from Maryland. I don't think we have all the facts around that, but America's Essential Hospital is doing an analysis. And to your earlier question, we certainly look at the facts that come from the CBO as we try to analyze the impact of any legislation.
Okay. Any of you deal in the rural America healthcare and challenges? Thank you.
I want to thank all of you very much. I want to yield to Mr. Scott, our ranking member, who's been here, as we know, throughout the hearing, and I know. Well, I yield to Mr. Scott.
Well, thank you, Stanley, and thank you for holding the hearing. This testimony puts a little meaning to some of the numbers we've heard. We've heard about 24 million people losing their insurance. Tonight, this afternoon, we've heard that for a cancer patient, it means the difference between getting treated for the end stage of terminal cancer, just being treated for symptoms, and under the Affordable Care Act, being able to get cancer screenings with no copay and deductibles where you can get early detection and coordinated services. Now, that's the difference between having insurance and not having insurance, and 24 million people will be caught up in that. For the rest, they'll pay more and get less unless they're in the upper 1 or 2% where they'll get huge tax cuts. And that's if this thing works. The CBO talks about stability, and we heard from the commissioner from Washington State about what that means when you try to cover people with pre-existing conditions without having a system where everybody gets covered. When they tried it, it raveled out of control to the point where nobody could buy insurance. So if it works, it's bad, but it might not even work. And so there is no rational reason to do anything that's not, unless it's going to improve the Affordable Care Act. We've seen improvements. We need to build on those improvements. And with the problems with this legislation, with fewer covered, the rest pay more, get less. If it works, and it might ravel out of control, there's no rational reason to pass this bill. And I thank you for holding this hearing.
Thank you. Mr. Palone.
Well, I want to thank all of you. I think that you really pointed out how this is going to affect real people, which is obviously what we care about. And I think the impact, obviously, of this Republican bill is unconscionable, and it's going to harm an overwhelming number of Americans. And I just wanted to mention, it has been mentioned that I'm the ranking member of the Energy and Commerce Committee, but I've repeatedly asked the chairman of our committee, over and over again, to slow the process down, so that, we can have hearings, we can understand the problems with the bill, that the American public can understand the impact on our healthcare system. And unfortunately, my Republican colleagues are determined to rush ahead. And Mr. Hoyer mentioned the Budget Committee, 45 minutes of debate, or 45 minutes markup today. We tried to slow this down. We had 27 hours in an effort to slow it down. But unfortunately, my Republican colleagues, they're determined to rush ahead, and I'm just concerned that they're going to do irreparable damage to the healthcare system and to the lives of many working Americans whose healthcare is going to, be ripped away from them. So I think we all share this concern, but this was a very good hearing in this panel in particular. Thank you, Mr. Hoyer.
Thank you very much, Mr. Palone and Mr. Scott and Mr. Lewis, and you had probably 25 members who came to this. We interrupted their schedules. We gave you short notice for this hearing. We gave them short notice so that, but the turnout was, I think, very, very significant from people who want to know, what is this going to do? And I'm a lawyer. I don't want all you doctors to be upset with me because I'm a lawyer. But one of the principles is, don't ask the question if you don't want the answer. Or don't ask the question if you don't know the answer. In my view, the reason there were no hearings is because the views that you have expressed and the previous panel expressed the opinions of the overwhelming majority of Americans who believe that the proposal to repeal the Affordable Care Act will hurt them, their families, their neighbors, and their friends, and their fellow citizens. As indeed it surely will, as you have observed, as Dr. Elmendorf observed, and as the present director of the Congressional Budget Office has observed. This legislation is not ready for the light of day. And that's why our Republican friends did not give it the light of day. There are 285,000 people who viewed this hearing on Facebook. There are another 10,000 people who viewed this on Resist Repeal. So we reached just about 300,000 people. 2,000 people have left comments. 96% opposed repeal. And 4%, I presume, although it doesn't say on this note, it just says 96 opposed.
Maybe they had no opinion.
Maybe the 4% either had no opinion or weren't sure. But in any event, I want all of you to know how much we appreciate your taking time, very short notice, to come here and to testify because you are speaking for the American people. And their voices need to be heard. Thank you very much.